quickly because we don't have a quorum. So we will proceed as if we did, but we didn't. Pretty much the story is we're live, so we should all be used to it. Anyone want to go first, agency-wise? You guys flip coins or anything?
Could OMH go first?
Well, who said what?
OMH?
All right, so OMH can go first. Thanks for volunteering yourself. But Keith, the problem we're having is we have a lovely shot of the podium and the screen with the Windows logo on it, but not many humans.
Do you have any humans?
Oh, there's Rochester.
Reveals a human.
The door.
Rochester has appeared.
Okay.
He's seeing that.
So you're seeing the podium. Okay.
Right.
We can see the 5 seats that are closest to the podium.
With 3 humans.
Yeah, that's all.
I'm trying to figure out where the camera's coming from. Up there. Okay.
Lights on now. Oh, you can see it's pointed that way. Just needs to be moved.
Oh,
That camera.
that's not our gear. I mean, we don't
It's not our lot.
unfortunately.
It's not their gear.
Move over to those seats.
We'll just move seats.
That's fine.
Well, you guys,
Here, they can see.
they can see that. Those 5
They can
seats.
see those 5 seats.
Just somebody moving.
You guys should move down too.
No, let's. How about we hold those seats open for speakers for now and the applicants?
Okay. Let's leave these open for speakers for OMH applicants and then move down, okay? That's a good idea.
I'm fine with not being seen. Totally.
Oh, on the spot. If they didn't want to hurt us. Oh, please. The other thing was we were equal opportunity. There was no race, creed, color, or anything that was not appropriately. If you were in my ED, you're having a bad day. So it was like.
Is that better?
This camera's moving.
Oh, is that better, Dr. Martin?
Yeah, we see people.
Okay.
Yeah, all right. We'll fake it.
Okay.
All right. So, OMH will begin. A lot of shrinkage to talk about today, and a couple of other things. So, Pete, what do you want to start with?
Should we start with Soldiers and Sailors Hospital?
All right. So, yeah, this is going to be entertaining if nothing else. So we're calling C-Part 23, closure of an inpatient psych unit of the General Hospital. Is anyone from the facility present?
Yes, we have representatives from the hospital here. Please come up.
All right, would they like to move to camera range?
Yes, they're coming up right now.
All right, there are 2 of them. They're both in camera range. All right, if you just like to introduce yourselves.
Hi, Ardell Bigos, Vice President of Nursing at Finger Lakes Health.
Frank Horich, Chief Operating Officer at Finger Lakes Health.
All right, thank you. All right, Pete, take it away.
Okay. We have comprehensive PAR number 23, Soldiers and Sailors Memorial Hospital. Soldiers and Sailors Memorial Hospital is a 35-bed critical access hospital in Penn Yan, Yates County, which is requesting approval to close its adult psychiatric inpatient unit via the decertification of its 10 beds so licensed. Following the closure of these beds, Soldiers and Sailors Memorial Hospital intends to continue to operate as a critical access hospital with a certified capacity of 25 medical surgical beds. During a prior consultation with the OMH Western New York Field Office and the Directors of Community Services from Yates, Steuben, Seneca, and Ontario counties on December 28, 2018, OMH clearly advised the administration of Soldiers and Sailors that the closure of the inpatient unit would not be permitted until final approval is given by both OMH and the Department of Health, including the Behavioral Health Services Advisory Council. Soldiers and Sailors submitted the required comprehensive PAR application to OMH on January 28, 2019, with a proposed closure date of February 18, 2019, citing low admissions, staffing challenges, and inability to fiscally sustain the unit. The hospital subsequently communicated plans to cease inpatient psychiatric admissions as of February 4, 2019. Specifically, the hospital contends that the closure of the psychiatric inpatient unit is necessary due to their inability to fiscally sustain the program or to staff the unit with the appropriately credentialed and experienced providers to adequately treat patients in need of this level of care. The application to close the inpatient unit has been met with a significant level of opposition. Community members, local government units, and town officials within the surrounding counties, and members of the New York State Legislature have all submitted letters to both OMH and DOH expressing their concerns about the potential negative impact this closure will have on those with acute mental health needs and their families in the Soldiers and Sailors catchment area. Following the submission of the PAR application, OMH Commissioner Dr. Ann Sullivan met with Soldiers and Sailors leadership on February 13th, 2019 and March 5th, 2019. In an effort to address the hospital's concerns and attempt to identify ways to support the hospital in its attempts to recruit appropriately credentialed staff to ensure the availability of psychiatric and prescriber services in this area of the state. In the February meeting, Soldiers and Sailors stated that although they were seeking to close the psychiatric inpatient unit, that their intention was to expand outpatient services within the community, despite the PAR application not speaking to this. Therefore, in the proposed absence of an inpatient mental health unit at Soldiers and Sailors, OMH has emphasized to the hospital administration the need to enhance the continuum of care in the community through the expansion of outpatient mental health services. OMH leadership and the Western New York field office have worked closely with the hospital to assist with and monitor staff recruitment efforts, collaboration with neighboring hospitals to ensure inpatient availability, ensure the appropriate access to treatment for individuals presenting to the ED with acute psychiatric needs, as well as assisting Soldiers and Sailors with developing a suitable plan for the expansion of outpatient behavioral health services. Specifically, OMH strongly advised the following measures be considered to offset the loss of the psychiatric inpatient unit. Development of intensive outpatient services for children, adolescents, and adults in their mental health clinic. Expansion of evening prescriber hours. Designation as a provider of child and family treatment support services. Development of a home-based crisis intervention program. Exploration of telemental health and/or mental health satellite clinics within local schools. Exploration of a partial hospitalization program for children and adolescents. Participation in stakeholder meetings at upcoming systems of care planning initiatives, and continuation of dialogue with the local DCSs relative to diversion apartments for adults. Aside from the expansion of evening prescriber hours at the clinic by 2 nights per week, the hospital has made little progress toward achieving the aforementioned items, nor have these efforts provided OMH with any level of comfort that Soldiers and Sailors will ultimately develop the array of outpatient and community supports necessary to offset the closure of this inpatient unit. Due to the hospital's inability to hire and retain the necessary staff on the inpatient unit, the unit has effectively been closed since February 15, 2019, when its psychiatrist departed and the last 2 patients were discharged. This effective closure occurred in violation of New York State statute and regulations. It is also important to note that Soldiers and Sailors did not approach DOH, OMH, or Yates County DCS regarding their staffing or fiscal viability issues prior to the initial notification of plans to close in November 2018. The failure to consult state and local stakeholders prior to announcing the hospital's intent only exacerbated the hospital's recruitment and retention challenges. Despite the lack of progress on the part of the hospital and a strong objection to the closure of the psychiatric inpatient unit, OMH has chosen to advance this application for conditional approval at the present time to allow OMH and the local government units to refocus our energies and efforts on strengthening the mental health delivery system within the region. Therefore, OMH is advancing this application at the present time for conditional approval, with final approval not occurring until satisfactory outpatient mental health service capacity has been developed.
All right, and the conditional approval would be based on them coming up with a plan that is acceptable to OMH to basically establish a worthwhile outpatient replacement.
I think it's more than a plan. I think it's actual development of outpatient programs.
Right, I understand.
Measurable progress seen in that direction.
Okay. And just a technical question, by this action, does it have any impact on, you implied that there were fines or stuff being levied on the hospital?
Yes, counsel's office is in the middle of assessing a level of fine to assess against the hospital.
And will this action in any way make that less onerous on the hospital or change the calculation in any way?
I have counsel's office here. I'd like to ask to chime in on that, but I would say that that the progress made between now and final approval, the effort by the hospital during that time could have an impact on the level of fine ultimately assessed.
Correct. All right, but by doing this, we don't suddenly stop the ticker, and there's no more fines being assessed if this doesn't go anywhere?
No.
I just want to make sure it affords the state whatever flexibility is required
Yes, sir.
to deal with this. Okay. So I know the applicant's there. I don't have any specific question for you at the moment. Do you have any statement you'd like to make? Any clarifications of fact that need to be made or anything else? We have one question. Yes.
So it sounds like this hospital has been operating adult psychiatric beds, and that's what they're closing. And in the conditions of being allowed to close, they listed the expansion or development of a whole bunch of services for kids and adolescents. IOP, PCI, etc. Does this hospital have any history of providing child and adolescent psychiatric services?
No.
They operate clinic services.
Do they operate child clinic services?
Yes, we see children on the outpatient side.
Okay.
All right, thank you. All right, again, my offer for any comments.
Yes, we'd like to make a brief comment. We appreciate the committee hosting us today and entertaining our application. I do want to emphasize with the committee that Soldiers and Sailors Memorial Hospital is a critical access hospital. And by definition, a critical access hospital is designated to provide primary health care, but in a limited way for inpatient and outpatient services. In New York, no other critical access hospital provides inpatient mental health services. It is not a sustainable model for a critical access hospital. Without the protection of critical access hospital reimbursement, which does not apply in the world of behavioral health, these are not sustainable programs. And across the United States, more than 90% of critical access hospitals do not provide these services. So we understand OMH's position, and we appreciate it that we all want to recognize there is a need for behavioral health services in that community and others. But at this point, we are the sole provider, and the resources in Yates County that we can draw from are extremely limited. Right now, the providers that we are utilizing in our outpatient clinic, both of them are locums, and we can't recruit. After 6 months of trying, we do not have a single candidate to take a 4-day-a-week, full-time position, no weekends, no holidays, no call. We have no applicants for what would seem like a pretty reasonable type of job. So we are now paying over $950,000 a year just for a nurse practitioner and psychiatrist to sustain the clinic in the form that it is today. And we've done some of the things that Keith mentioned, and Ardell will talk more about those briefly. But when we look at being there for the community, and our board's goal is saying that we need to keep the critical access hospital, the only hospital in that county, viable for the foreseeable future. We cannot do that when we don't have the resources, meaning the skilled talent within the county or even within the region. So many of the people working there, they're not local. So there's many other opportunities, Rochester, Syracuse, Ithaca, so they don't want to travel those long distances to come and work for us. And that's really one of our big challenges, is finding the talent to do that in a way that is fiscally affordable and sustainable. We cannot start additional programs that we cannot sustain from a resource perspective. It's a county of 25,000 people spread out over 386 square miles in a shrinking population. So in that county, we take care of maybe 20,000 covered lives. We are already subsidizing heavily the emergency department. That is required as a critical access hospital, as well as laboratory and x-ray. We are subsidizing physician programs for the hospitalists for inpatient care. We are subsidizing and by and large provide 90% of the primary care in the region. Again, we can't recruit these physicians. No other organization has brought physicians to the region. They can't reasonably do it. So we have a high level of subsidy already, and behavioral health obviously is being highly subsidized. If we continue to expand in areas of low utilization, the problem is that the critical access hospital cannot sustain itself to be there for the community in the future. So our board has to make very difficult decisions. None of these are easy decisions that says, where can we invest our limited resources that do the most good? No doubt there's need, but there's need in many areas, and our resources truly are limited as a critical access hospital. And again, behavioral health outside that critical access hospital protection, meaning 1% over cost, very quickly it drains the resources of a small community hospital. I'll let Ardell speak about the number of things we have already implemented that were on your list, and why we're certainly in favor of those, but others we're not going to be able to move forward in the way that you may envision. Please.
Actually, I don't think that's a particularly useful use of our time at the moment, to be quite frank. All of that explanation, I'm pleased that psychiatric care doesn't appear to be considered a crucial care element of your planning, and that's all I'll say about it. Right now, what's been presented to the council is the hospital has been totally out of compliance with its closure, that in order to move this along and do what's necessary for the citizens of the county and allow the offices that are responsible for it at a state level to proceed, is we're being asked to approve closure with those conditions. If there's anything in particular that you'd want to state about that at this point, that would be helpful. If the conditions you think are onerous or impossible, you can say that. I don't know what to change.
Sure.
That would be useful. Otherwise, there's really, I understand your position is just one that is not particularly germane to our decision today.
Well, certainly we want to.
That's fine.
We want to keep the outpatient behavioral health program operational. That's been operational for many years in support of the needs of the community. And Ardell will mention the ones that we're doing and the ones that are problematic for us.
So presently, we expanded, as Keith noted, we expanded our evening hours to make sure that we're able to reach clients in the community past the normal business hours. So we expanded 2 evening hours. We expanded to also the NPP, both locums and also the physician to cover those hours, and also to help facilitate psychotherapy, which we were not doing prior, in order to get through our wait list as well to make sure that we're meeting the needs of the community. We have done that. We looked into inpatient, the outpatient services, the intensive outpatient services. We've been working really closely with the regional office on what that looks like. We developed a plan. It was presented to the regional office at that time, and they felt that we should start, the recommendation was to start with group therapy, not the intensive outpatient services at this time. We have developed a curriculum that will go and get reviewed by Nicole at the regional office, and then we'll proceed with our groups, which will include teen group programs along with stress relief and some other group therapies. So again, we're getting that approval on the curriculum, and we'll move forward with that. And so those are some of the services. The telemedicine with the schools, working very closely with the school districts, the superintendents. We purchased the equipment. We're ready to go to install the equipment. I have had multiple meetings with the schools. We just have to work out the process on their side, how that's going to work to make sure that we're within the regulations on how that can be obtained with children and adult approval. I have another meeting scheduled next week to finalize that, again, based on the school's approval to move forward with that. But we're ready to go to offer that service. We're all set. And so those are services that we have expanded. We're very dedicated to expanding the services. We also last year had over 1,000, close to 1,500 cancellations and no-shows. We're trying to fill those as quickly as we can. So when we have a no-show, working off the wait list to get people in who need that service.
Okay. Thank you very much.
You're welcome.
Any questions from committee members to start?
So I'd like to know what happens when people need a hospitalization at this point from the current services.
If they need hospitalization, if they come into the ED, they will be evaluated in the ED, and then we have a process in place with both Strong and also with RRH that we then notify their transfer center, and then there's a conversation peer-to-peer, provider to provider on whether that patient would go to CPEP. And be evaluated, whether they need to be admitted or they could be discharged. We also have crisis counselors that work out of JDK, which is our outpatient clinic 24/7. So they're the first ones to be called. They're evaluated by those crisis counselors first, and they work in conjunction with the ED provider.
How far away are those hospitals?
About 25, 30 minutes.
I have one final question, if no one else has one. Is there some reason why this wasn't done the right way?
You know, I think in talking with normal process, because we've had to make other difficult decisions, the first decision is to notify the Department of Health. The Department of Health then asked that we notify OMH. So we really followed the process that was outlined for us by the Department of Health. So we did exactly what they asked us to do in a very timely manner. Within essentially a day of what they communicated to us, we communicated to the Office of Mental Health. So I understand that's not the process that OMH would like followed. However, it still does require DOH approval ultimately, even after OMH approves. So we started with the final agency, and that's the guidance they gave us. And I'm not throwing them under the bus. I'm just saying that we followed what we believed was the process through them, which starts and ends with them.
Okay, thank you. Any other questions? Huh?
Very distressing.
All right.
It's obviously not a situation that's unique to you.
All right. So on the specific question in front of us, the motion is to allow for the closure with the contingency being the successful development of delivery of community-based services that OMH has discussed with and negotiated. So Sailors Memorial Hospital leadership. Any further discussion on the motion? Seeing none, we'll vote committee members only. All those in favor, please indicate. I've got 3 votes for in the room. I can't, are there committee members in Albany? I can't see.
No, the only members right now are in the city.
Okay. Is anyone voting negative? 1 negative. Any abstention? There shouldn't be, there are only 4 of us. Stand. All right, so the vote was 3-1 to approve, but again, in an advisory capacity only. Next. Keith?
Which application, go back to the beginning, or?
Yeah, whatever you want.
Okay. So let's go with...
We might as well put 16 and 24 together.
Yeah, that's what I was thinking.
Cash has got to confuse himself. I don't want to put his fingers in his ear. It's too much.
So we have comprehensive PAR number 16, the Jewish Board for Family and Children Services. The Jewish Board of Family and Children Services, JBFCS, originally submitted this PAR application to request permission to officially reduce capacity at the Sally and Anthony Mann Center RTF program located in Hawthorne, Westchester County by roughly 20% from 64 beds to 51, reflective of the fact that 13 of the program's 64 beds had effectively been offline since November 2016 due to a reduction in referrals that year and the subsequent renovation of an entire unit. In addition to a desire to right-size the RTF's license capacity to that which it currently functionally operates, JBFCS is also proposing a new program structure for the Mann Center which better focuses on addressing the clinical needs of the children and their family, as well as the safety of the youth within the facility. Dialogue throughout the review process centered on what the ideal capacity of the RTF should be, based upon historic occupancy and staffing levels. Ultimately, it was agreed that the RTF should reduce to a capacity of 40 beds, which both OMH and JBFCS believe best positions the RTF to most effectively and efficiently serve the youth referred to them for treatment. OMH, therefore, is recommending approval. Should I likewise present 24, or would you like the...
Yes, please.
Okay.
Yeah, they're basically...
Yep, certainly. Comprehensive PAR number 24, Jewish Board Family and Children Services. Similar to the one I just discussed, JBFCS has submitted this application to reduce capacity at the Goldsmith Center for Adolescent Treatment RTF, also in Hawthorne, on the same campus actually, by 20% from 50 beds to 40 beds. The applicant has indicated the program has been operating at an estimated capacity of 80 to 85% for the past 6 to 9 months, and that there are currently 10 unoccupied beds. Like the Mann Center proposal, this proposal represents a new program structure for JBFCS, which better focuses on addressing the clinical needs of the children and their family, and it addresses a national and statewide trend for shorter lengths of stay in one of the most restrictive levels of care in the children's behavioral health continuum. The new capacity will allow JBFCS to respond to the ebb and flow of demand for this level of care as the RTF focuses its efforts on achieving shorter lengths of stay and improving bed turnover. OMH is recommending approval.
Okay, thank you. Representatives from the organization, you want to introduce yourselves?
Yep, my name is Manny Rodriguez, and I'm the Executive Program Director for Children's Regulation.
Thank you. Okay. Anyone on the committee have a conflict they need to discuss? Okay. The council. Okay, any questions that anyone has? For what appears to be a relatively straightforward application.
Explain to me why you feel your census is lower.
I think that we've seen a reduction in referrals, partly because I think there are some services that have been put in place in the community. I think our length of stay has gotten shorter, so we're able to move children back into the community with their families in a much quicker way. And I think this gives us an opportunity, and with the approval of OMH, there should be a trend increase in the number of services needed for these children. There is an option with approval from the Office of Mental Health to increase the capacity by 10%. As the report states, we've seen a decline of referrals because many children and families are being referred to some of the newly developed outpatient services that have been put in place over the last 2 years.
Okay. Any other questions or concerns? Do you suggest that this is a good thing?
I think it's the right thing. I think we need to develop more outpatient services and other services to continue the initiative that we need to take where we serve these children and families. But given the current trend, I believe it's right.
But, all right, let me ask you that. But it's a cart and a horse question. Are we ahead of ourselves? So, yeah, are you saying that, are you reacting to the fact that outpatient services have gotten so good, or other services have gotten so good, that we don't need the longer term residential to the extent we need it? Or are you saying we'll do this and then the other stuff magically will appear and then I'll pick up the slack?
I think what's happened is that the community services have developed, but we've also on the community ourselves have done some new stuff that we haven't done before. For example, we've done building bridges condition over the last year or two. We've been focusing more on getting out what we're calling RTF without walls. So we're getting out to the community and doing what we're doing in the facilities with families in their communities. So I think that's pushed the length of stay to a shorter length of stay. And so that's a combination of that and developing services.
Yes.
It always terrifies me when we close residential beds for kids, which we've been doing quite systematically over the last few years, just stages to close. There was a pre-remodel that was, Bellevue Hospital is located in the Children's Center, which is the reception center for kids who don't know where to go, and many of them are older kids who are quite challenging and have often been in their services. We highly value the services that Sally Mann is highly. Sally Mann's specialty program for girls with sex trafficking is very unique, very hard to operate. I appreciate that. Very unique. I personally don't see the outpatient growth and the outpatient services level of intensity that would match the needs of kids and families. I do not think the HPCS services are a solution to this level of complexity. These are not simple kids that have not been families or single either. So, just as somebody who watches the flow of kids going through what's supposed to be a brief reception center, and watch the population of kids that stay there longer and longer expanding, it's problematic. I understand why you're doing what you're trying to do. I would argue that we do not have robust enough outpatient services for these kids and families. Have you given any consideration to opening additional younger kid beds? Because there's one RTF for kids under 12 in New York City and environs, and that's a huge need.
Yeah, we would consider that. I think he's referring to our Wilson Center, which would operate about 146 beds, or roughly around 500 beds in the state of New York. Originally designed in the 1980s. That total number has been reduced, and we are now, as the report indicates, moving from Command Center from 64 bed capacity to 40 bed capacity, and goes from 50 to important. We would be open to talking with the Office of Mental Health about using some of our beds for younger children like we treat at the AOC Center.
With the same community enhancements that we're working on, that might be, because the reality is we wait till these kids are like 14 or 15 and they're big enough to make them enough trouble. They have to leave their home. We don't have enough interventions for mental puberty's moving now, literally. I mean, I just think it's worth thinking about.
Yeah.
We really value innocence, and as we discussed earlier, we are not intervening appropriately with those children when they're younger and easier to intervene with.
That's a point well taken. You know, we're open to working with the Office of Mental Health to address the shifting needs. You know, 15 of the 146 beds were increased probably about 10 years ago in response to a trend that went the other way at the request of the Office of Mental Health. So we would be open to, you know, depending on.
You still have the real estate.
You still have the real estate.
Again, there was something about selling stuff.
Well, they closed many of the small programs in New York City, but John Madden did that, and they'll never get those back.
Okay. Any other questions? Yes,
Those
Dennis?
financial question. So the new model has 534,000. What was the deficit under?
Well, under the old model with the empty beds was significantly much more than that. Yeah, and just with regards to the deficit, I mean, the organization is, I believe, to provide some foot traffic to support that. Part of the deficit is that there are a couple of enhancements that we've made over the last year. One of them is security at a very high cost to make sure there's great security on the campus. The other is that, unlike perhaps other RTFs that may sit on a standalone, we sit on a campus that requires the operation of
Lenny, do you feel that your rates support your costs?
no.
And do you
If I'm
have,
going to be frank,
do you have staffing issues?
we, as with any other part of the state, I think we are in this field really struggling to recruit and retain experienced staff. And that, I think is this board, but for many other providers throughout the state.
I also think that with the development of other programs in communities, some of the kids that have lower acuity are in those programs, so we're getting a more concentrated number of very, very difficult kids, very complicated needs, and because we're dealing with adolescents, there are lots of systematic education and other things that we need to address. So while it looks like this is a robust staffing model, really it's the bare minimum you can do with the complexity of the kind of kids we're seeing now. And just the kids that we have, I mean, I know we need to look at things like ensuring people are watching our cameras and our doors because we have to keep them safe in a way that these just were not the issues that we had years ago. Safety, especially with our CSAC population.
All right. If there's no further discussion, I think we can move to vote on these. We'll do them as two separate votes, so council remains calm. So we'll vote first on CPAR 16. This one is to reduce the demand center?
Yes.
All right, 64 down to 40 for the demand center. Any further discussion on CPAR 16? If not, we can vote. All those in favor? All right, so it's 4-0 in favor. We then have its cousin, twin, sister, whatever. CPAR 24, which is the Goldsmith Center going down to 50 to 40 beds. Any discussion on that? Seeing none, we can vote. All those in favor, please indicate it. And again, that's unanimous for those in the room. Thank you. We'll transmit that to the full council for action. Actually, the action is coming. Sure, thank you for coming down. And good luck. Keith, why don't we skip Alley Valley for a second? Let's just go to Center for Discovery.
Certainly.
Just knock that off. I think that's pretty straightforward.
Yep. Okay.
Is the applicant here for that? If you'd like to come up to the table, if not, it's up to you. All right, Keith, take it away.
Okay. We have NHE 2828, Center for Discovery, Hamptons, LLC. The applicant is requesting approval to change member ownership from current member Dr. Craig Brown to new member Dr. John Peliquin, as Dr. Brown is entering retirement. Dr. Peliquin will hold 100% of member shares. Center for Discovery Hamptons, LLC is currently licensed to operate an 8-bed community residence for eating disorders integrated treatment, a credit program for adolescents. It's located at 3 Sunset Avenue in East Quogue, in Suffolk County. This program provides 24-hour care and supervision to residents in the prevention of destructive behaviors and underlying emotional issues of binge eating, bulimia, anorexia, and other complex eating disorders. The application indicates that Dr. Peliquin has over 20 years of experience working with behavioral health facilities, including eating disorder programs similar to the program run by Center for Discovery Hamptons, LLC. Dr. Peliquin has served as Chief Executive Officer and President of Discovery Practice Management, DBA, Center for Discovery, since 2018. Center for Discovery operates 46 eating disorder programs which provide both residential and outpatient levels of care to clients in 11 states. In addition to his experience with eating disorder programs at Center for Discovery, Dr. Peliquin managed the residential and outpatient eating disorder programs as a division president at Acadia Health from 2004 to 2017. OMH is recommending approval.
Thank you. Could you guys introduce yourselves? I realize that.
I'm John Peliquin.
I'm Deanna Christensen, the Eating Disorder Division President.
Marcy Marcella, Center for Discovery.
So Keith, as I understand it, so the program as it has been operated without Dr. Peliquin has doing well, and the programs that he has been associated with in California, as best we can tell from California, has been doing well.
Correct.
Okay,
I can tell you that on visits, the program, staff have been impressed with the services. Areas that we have recommended for improvement have included better interaction with the local mental health delivery system, and in particular the counties. And they have been receptive to that.
All right. And again, when we do our diligence, competence and all of that, I assume Dr. Peliquin's professional credentials, records, and everything else were checked in the school?
Yes, sir.
Thank you. All right. Okay. Any questions? Any questions from anybody? Committee members, council members? Here, Albany? No one. The motion will be to approve the 100% transfer and ownership from Dr. Brown, who is out of here, and Dr. Peliquin, who's coming in. Seeing no further discussion, we shall vote. All those in favor, please say so. Raise your hand and do something. All right, 4-0, unanimous. We will let them know later today. Thank you. All right, let's see, what time is it? 10:29, fine. On the, I'm not forgetting the last one. Just on the Oasis end of things, just want to confirm the last house on the block couldn't make it today. They have withdrawn, or they've withdrawn for some reason or other?
Yeah, they'll probably come back in August.
All right, so we just have the two other providers. Okay.
Yes.
So we've got two relatively appear to be straightforward Oasis, and we have what's that? The first one, last house on the block.
The first one out, last house in the front.
All right, so Alley Valley Clinical Treatment Program are coming back. This is a repeat visit. There are, so let's see who's in the room who's going to be talking about this. And what do I got? I got the applicant here. Who have I got?
there?
You should have the applicant there, Dr. Martin. I have their attorney here with me, and then we have a gentleman as well appearing to speak against the application.
All right, so I got a whole bunch of people in this room. Why don't you introduce yourselves and your positions in life as it pertains to this?
Yeah.
Brian Baldwin, Cicero Associates.
And you guys are supporting this application, something supporting the application. Okay, and in Albany, what have we got?
Peter Millock, Dixon Peabody, counsel to the applicant.
Dr. Isaac Schechter.
Okay.
Dr. Isaac Schechter, Chief Clinical Officer at Achieve Behavioral Health. We have one request.
I'm sorry, you said you had a request?
No, we have just a comment.
Oh, yeah, okay, that we're talking, okay, fine. So, all right, Keith, why don't you present the application and remind us why we're back here and what's going on?
Certainly. The application, MHC 2807, Alley Valley LLC. The applicant, a newly established for-profit company, requests approval to become an Article 31 sponsor for purposes of establishing a mental health clinic treatment program for children, youth, and adults to be located at Route 59 and Cole Avenue in Spring Valley. You may recall, in September 2018, this application was presented by OMH to the committee without recommendation. Specifically, at that time, OMH believed that the applicant had not demonstrated the competency to operate an Article 31 clinic treatment program. Much discussion took place at that meeting, and in the end, the council chose to defer the application until a list of deliverables were met by the applicant, in particular requesting the following: description of the intended population more thoroughly, more information to support need, description of the applicant's clinical approach, creation of a more robust governance structure, including individuals with experience in the provision of mental health services for children, addition of individuals with more pertinent experience to the clinical operation, including individuals with experience in the provision of mental health clinic services to children, clarity on the supervisory structure for the clinic, resolution of all outstanding fiscal issues and concerns, documentation of engagement with the local government unit and other providers in the community, and identification of a site for the clinic. Over the past many months, the applicant has retained a consultant and worked diligently to address all issues identified by the council and OMH. To address the competency concerns, Alley Valley has received commitments from experienced individuals to join the clinical staff of the proposed program, as described in the review. In addition, they have now obtained the support of the county for the application. As a result of these efforts, OMH is now in position to recommend approval of this application.
Thank you. So, yeah, just to recap, because we remember when they first came here in September, I think the best way, it was more of a concept than a proposal. It would be, I think, that many of us looked at that it seemed it may be a reasonable idea, but it wasn't fleshed out enough to really take any action, which is essentially what we said, and apparently the applicant took it to heart and has fleshed it out with real people proposing to do real things, which is really good. Actually, let me go a little bit out of order. So we do have another provider in the area, Achieve. That, I mean, why don't you explain to us why you wanted to speak today? Because I guess I'm still not 100% sure. So that would at least put it in some context, and we'll figure out how best to handle it.
Sure. Okay. My name is Dr. Isaac Schechter. I'm the Chief Clinical Officer at Bikur Cholim, Achieve Behavioral Health. We want to basically just raise concern, but really just provide clarification on context for this applicant intending to offer services for a very similar or a completely similar target population that we currently serve. Bikur Cholim Achieve is a not-for-profit community-based organization serving the community for almost 40 years, and we're a very trusted organization in this culturally insular community, serving primarily the historically underserved Orthodox, ultra-Orthodox, and Hasidic communities. It started to provide behavioral health services, given the unmet needs, stigma, and lack of culturally matched treatment. And Bikur Cholim has really dedicated itself to this cause and has become a real pioneer and leader for this community and beyond, with the mission of providing the highest level of behavioral health services with professionalism and cultural sensitivity. And we currently offer a very wide range of clinical and community services through our CCBHC, that's the Certified Community Behavioral Health Center, and multiple clinical, school, and community sites. Currently in Rockland County, which is the smallest county in New York State, and serving this population, there's our service, the CCBHC and the integrated iOS, mental health and SUD service, 2 FQHCs with behavioral health services, 2 non-OMH clinics, as well as the county services, and 4 other licensed clinical services. In the past, we have supported other Article 31 applications and continue to offer them support in their development. So let me give you a little bit of a run through of where we are up to. As a CCBHC...
No, stop.
Sure.
Because, all right, because I don't need...
Okay.
I don't want you to establish it before we let the applicant speak. So you're speaking, so then you're formally speaking in opposition of this?
Well...
because your letter was unclear. It was, you're clarifying, you're this and that. I just want to put you on the spot.
Sure.
Are you opposing this application?
We are requesting that the committee defer decision until a current and accurate needs assessment demonstrates unmet need or gaps in services. And that's what, yeah.
Okay, I got it. So so all right. So if I'm just summarizing in my own head,
Sure.
Is that your agency's been there for a long time. It's been growing. It apparently has been doing well. It is getting rated appropriately. It's fine. There's no reason to think otherwise. This agency wants to open up in your backyard, treating basically the same sorts of people with the same sorts of issues, with the same sort of expertise that you've been offering. And the question that you're raising is, do we really need somebody else here, or are we going to just dilute services, make it harder to staff up, and basically screw up a system that's working well, and why not leave?
That's a pretty short summary of it, yeah? And we've grown in our child services very dramatically and continue to do so.
Good. Excellent.
Okay.
All of that's good. So I guess, why don't we let the applicant speak for a little bit about what they've accomplished so far in terms of meeting the needs that we had laid out, and more particularly, if they could, focus a little bit on the needs of the community, why you think this is not duplicative or isn't going to be somehow a negative impact. And Keith, please be prepared from your perspective also to talk about the needs analysis that allowed OMH to support the application. Let's let the applicant go first.
As we laid out to
I'm sorry to interrupt. Can we have the representative speak up a little bit louder? We can't hear in Albany. All right, thank you.
Frank Cicero, I'm a consultant representing the applicant. Just want to present 2 numerical facts about public need before the others here speak. In what we presented to the State Office of Mental Health, in late 2016, less than two and a half years ago, OMH produced a report regarding DSRIP on a regional needs basis. And in that report, it showed that Rockland County had the lowest penetration, lowest utilization of every county in New York State of children in the mental health system. We don't believe that's as a result of better mental health. So it's the worst in New York State of 62 counties. Second of all, as OMH cited, Rockland County's Medicaid eligible population, and this application will have approximately 70% Medicaid utilization, is designated by the Human Resources Services Administration of the federal government mental health medically underserved population. And it may be that there's been some improvement in the county over the past two years or so, but we certainly don't believe, and that's why they've applied, that it has gone anywhere from the bottom to the top. That has not occurred. So those basic public need as defined by OMH and the federal government in this county. So I'll stop there.
Yes. OMH encouraged us to meet with the local governmental unit, Michael Leitzis, and Dr. Hortzer of the Rockland County Department of Health. And we presented a lot of material to them concerning the need for this type of program. I know, I heard what the gentleman said, that Rockland County is the smallest county, but Rockland County has only exceeded in population by 12 other counties out of 62. It's a fairly significant population, and in terms of the number of clinics per capita, mental health clinics per capita in the metropolitan area, Rockland County is the second lowest. The only county that has a lower per capita number of mental health clinics is Nassau County. Rockland County has only 5 clinics. And, we certainly endorse the idea that Gifford Petroleum is doing an excellent job and has good services, but we have demonstrated to Rockland County, and they have recommended approval of the application, that there is a need, and that we have promised that in addition to the target population of the Orthodox Jewish population in Rockland County, that Alley Valley will also reach out and provide services and competent and culturally competent clinicians to serve the Asian community and the Hispanic community, which are also an important population with needs for mental health services in Rockland County. So, we understand maybe the concern of another provider to have a new provider in the system, but as Frank just pointed out, there is a great need in Rockland County services for children and also for adults. And Mr. Truly Oster and Mr. Mayor Oster have lived in Rockland County. They know the needs of the community. Mayor Oster is a social worker, and part of this is his vision to establish a clinic to serve the needs of both the Jewish population and the Hispanic and Asian population.
Keith, let me just jump to you. Can you discuss the need methodology and how OMH concludes that this is a reasonable application to support?
Certainly. So, as was stated, Beaker Colum is a strong provider in our system, a CCBHC, participating in our CCBHC demonstration program, and is a provider agency that continues to expand in the region. So that right there shows that they likewise identify that there is a need for more services as well. They are a large, strong agency that we honestly do not see Alley Valley, this application, having a negative impact on. That if the need that Alley Valley has identified truly exists, if there is an underserved need even within this population, that the ability to serve those individuals, we don't think would have a negative impact on Beaker Colum. In addition, as Mr. Baldwin stated, when meeting with the county highlighted segments of the community where they believe a need does exist, and the applicant was responsive in presenting a plan and staffing with competencies to be able to address the Haitian and Latino communities. So there is responsiveness on the part of the applicant to work with the county to identify pockets and meet the pockets of unmet need that do exist in the county, and we don't think that Alley Valley will have a negative impact on Beaker Colum.
And that the community does in fact have the needs analysis and supports more treatment.
Yes.
And there is, and I'd ask counsel, this comes up in some of the other places I said, there's no statutory responsibility of this council or committee to look at fiscal impact and competitiveness in our determinations?
No. Just shaking his head no.
Thank you. Presentation. There's a need, in fact, that somebody create a new business. Stop. So tell us a little bit more, because so now I'm sorry. So now you got something here, but I got to get a better handle on the meats and the bones. You're going to treat kids. We're doing families. What do we end up doing? What's our staffing? What are we doing?
Yes, you know, there were some questions about the adequacy of the staffing, but we demonstrated to Rockland County in our meeting with them, as well as in our written material to OMH, that we have the staffing is a medical director, a psychiatrist with competencies in treating children as well as treating adults. We have a nurse practitioner, full-time nurse practitioner with those competencies, or the equivalent of one FTE nurse practitioner with those competencies. We have 10 therapists meet the OMH criteria for qualified health professional, social workers, psychologists, mental health counselors. And, you know, we've demonstrated to OMH, and they've agreed that that number of staff is adequate for the number of visits that we propose in our staffing and our budget.
And Mayor, I think you should state to the council and the committee what you've done for the last 8 or 9 months to meet with folks and bring them into your application.
So we brought in the ownership, Joel Isaacs, and he's also from the community, so he became part of the community. And we brought Lori Diamond, she's very experienced and all the good there. And we brought in from our community many social workers. Yiddish, we're going to bring in from other minorities. We're going to bring in also once we open. We're going to try to serve not just our community, all other communities, not just folks ourselves, and have the best clinic we can possibly make.
Right. And Mr. Isaacs is an experienced social worker, works for another provider in the region. And he's going to be providing the clinical oversight as part of the ownership. And as Mr. Oster has stated, Lori Diamond is a very experienced social worker, has worked at Rockland Psychiatric Center as well as Westchester Medical Center. She has experience with both adults and children. And, you know, I think Rockland County was very glad that those two people, that Mr. Isaac was brought into ownership, and Lori Diamond would be part of the staff, should be the clinical director.
So the medical director, psychiatrist, who was identified is Dr. Price.
Dr. Price is child.
Has experience.
Yeah, he's not a child psychiatrist, but he has many years of experience providing services to children. In fact, Dr. Price works at the children.
Excuse me, I'm sorry to interrupt again. When you are speaking, can you have the microphone moved to where you're speaking? Just because we lose hearing you.
It's a little different.
All right, thank you.
All right, let's try again.
Sorry, I was just grinding the same axe I always grind about adult psychiatrists serving children with Dr. Price, who I don't believe is board certified or board eligible in child psychiatry. Maybe he is, but he certainly isn't. And so that's an issue for me, especially if you're focusing on the child and adolescent population. And I don't see the clear demonstration that your licensed clinical social workers have experience working with children. So maybe you could lay that out a little more for us.
Okay. We discussed the qualifications of Dr. Price with Rockland County and with OMH, and yes, he's not a board certified or eligible child psychiatrist, but he has many years of experience treating children. And as a matter of fact, he works at Picker Cholm treating children. So, I mean, I understand, Doctor, your concern, but
I disagree with access issues.
Well, child psychiatrists, board certified child psychiatrists are, you know, they're very scarce. Yeah, they're very, there's not many of them. So, and Lori Diamond, yes, for many years worked on the adult side at Rockland Children's Psychiatric Center, but more recently, for the past few years, she's worked at Westchester Medical Center as the supervisor of 2 children's programs. So her most recent experience is with children. Yes, right, and the person in ownership, Mr. Isaacs, is the director of the clinic that serves both adults and children. He actually provides some direct care to the children there, so he's an experienced.
My concern is always about medical management of child psychiatrists. There are some nurse practitioners who are quite excellent, and many nurse practitioners who are very junior, and you can want access to child psychiatry background. So that would be my own. And I understand it comes up a lot.
Right.
I just don't feel it.
And again, we should mention that it's not a regulatory requirement. It's like in-house. All right. Any further questions for the applicant at this time?
I have a question about we have 6 staff therapists, including contract therapists, additional therapists who will work on a real basis.
Correct. The contract therapist would be for various reasons. You know, the clinic is going to be open just more than 9 to 5, so being able to get people who work the evening hours, sometimes you have to offer, you know, them a per diem position. Also, you know, as you mentioned, the recruitment of you know, people with competency to serve the Hispanic population and the Haitian population, same thing. You know, that's really the reason for the mix. In other words, there's going to be 6 salaried full-time therapists, which is, you know, a good strong number, and then the rest of the hours equivalent to 4 FTEs.
How many patients are going to treat? Because we have these units that drive me nuts. Just how many?
Yeah, I think the target is somewhere, you know, maybe 200 patients.
What proportion do you project?
Yeah, I think we had said that there's going to be a large percentage of children, you know, probably 60–70%.
But you will be treating adults, so that'll give you the capacity to then treat families.
That's right.
Just curious, the quality standards for the therapist,
I believe the average number of visits would be 1275 a year, which is well within the OMH standards referred to.
Your brave soul owns this.
Yeah, we had a lot of defense.
All right, does anyone have any other questions for the applicant? Does anyone have any? Yeah, I was going to I just want to make sure that we spoke to the applicant about our questions. So I'll give you 2 minutes to sum up whatever it is you'd like to, sir.
Thank you. The fact that they are retaining a psychiatrist from our staff, as well as the concern about child psychiatry, highlights the point that having another agency such as this for this largely same population does harm on the staffing and does direct potential harm for staffing and makes retaining of staff that are culturally sensitive and culturally trained more difficult. And I would like to consider that. And the very child psychiatrist issue and the other staffing. Our services have, we get 30 calls in a week for service. We have we have open access and walk-ins. And as we've reported to the state, intake to evaluation is less than 7 calendar days. So the potential harm of the staffing is a serious issue. And all the while we have 15 or 17 schools that are already signed up with us to work with us to have clinic-based service, school-based clinics. So we want to bring those points to attention to the committee and would like to understand the current and accurate needs assessment to this with the potential harm in staffing. Thank you.
Okay, thank you very much. Any particular questions for Dr. Schechter or Chief? Not seeing any, the motion will be to approve the application. Were there any contingencies on this? And with the contingency of listed?
Just legal paperwork.
Yeah. Any further discussion at this time by the committee members? Seeing none, the committee will vote. All 4 of us, not necessarily together, can vote. All those in favor, please say aye. Raise your hand. Aye. Anyone saying no or abstaining, 4-0 will be the recommendation going forward to council. That will be later. Good luck to you. And to Chief, we wish you only the best also, and that hopefully your 2 organizations going forward will be able to work together collaboratively and just increase the care in that community. So we wish you both well.
Dr. Martin, we stay for the full
If you like, I'm not totally up to you. They make me stay. You're thank you. All right.
That's very good.
All right. So I imagine we're swapping positions in Albany.
Yes.
All right, and we can start with Linda whenever she's ready. We'll do Riverhead Community Awareness Program.
Okay. Before I start this, I need to make one correction to the application. Felicia Skakoza, the executive director, was inadvertently included as a board member. She is, in fact, not a board member of Riverhead CAP. I just want to say that right up front. So this is Riverhead Community Awareness Program is requesting OASIS approval to become a new OASIS provider of prevention counseling services in 4 schools in the Riverhead School District. The 4 schools are Riverhead High School, Riverhead Middle School, Phillips Avenue Elementary School, and Roanoke Elementary School. Riverhead Community Awareness Program has began as a coalition of community members of the Riverhead Central School District in 1979 and became incorporated in 1986. They began receiving funds from Oasis, and actually prior to that, DSAS, in 1989. The services to be provided by Riverhead CAP include peer leadership training, assessment, counseling and referral services, and life skills training. Riverhead CAP states that their mission is to reduce and prevent alcohol and substance use within Riverhead schools and community. The 3 specific goals of Riverhead CAP are to prevent and delay experimentation with alcohol or any drug by school-age population, to prevent experimentation from escalating to abuse, and to prevent the use of alcohol and drugs from leading to serious harm to the individual's family, peers, and community. The applicant has been a provider of prevention and prevention counseling services in the area for 30 years. They have community members on their board and are also involved in numerous community-wide prevention efforts and partnerships. They also serve in an advisory role for many community coalitions and agencies and sponsor community events and provide trainings within the community as well. Prioritizing prevention services, especially in the areas of underage drinking and youth marijuana and e-cigarette use, is listed as a priority in the local services plan. And according to the applicant, the Riverhead School District is the largest on Long Island and also includes the most impoverished areas of Southampton. There's a great economic disparity within this town, apparently, and despite the wealth that surrounds them, 53% of their students and families are classified as economically disadvantaged, and an increase of 26% since 2013. The applicant also states that gang activity and violent crime in downtown Riverhead are on the rise and that neighborhoods are littered with empty beer bottles and gang tags. Public transportation is limited and there are no movie theaters or YMCAs for the youth. The Youth Bureau was eliminated in 2012 due to a budget deficit, and when New York legalized marijuana, Suffolk County's only dispensary opened in Riverhead. Medical marijuana, that should be. Wineries and craft breweries continue to crop up in the area, and many of the festivals that are held in and around Riverhead are focused on these industries. The Suffolk County Department of Health and the Long Island Regional Office both support this application, and the Long Island Regional Office has stated that the program is consistently exemplary in many areas and receives local and national recognition for such. The character and competence applicant review form included with the application was reviewed, and there are no concerns related to the character and competence of the applicant. Riverhead CAP's fiscal viability information was reviewed by our Fiscal Audit and Review Unit on June 12, 2019, and they were found to be fiscally viable with current assets of $278,001 and current liabilities of $106,662. The budget submitted with the application appears to be appropriate, and Riverhead CAP is an OASIS-funded provider, and they received $466,718 from OASIS in this past fiscal year. The floor plan, secret, and physical plant inspections were not conducted by OASIS, as the space being utilized falls within the purview of the New York State Education Department. Fire drills and fire alarm inspection records were included in the application. Each school is staffed by either an LCSW or prevention specialist for all hours that the schools are in operation, and the Riverhead High School serves approximately 30 students annually. Phillips Avenue Elementary School serves approximately 14 students annually. Roanoke Elementary School serves approximately 17 students annually, and the Riverhead Middle School serves approximately 35 students annually. Staffing meets or exceeds the recommended staffing in the prevention guidelines. Policies and procedures have been reviewed using the prevention guidelines and the prevention counseling site review instrument as guides, and they're accepted by OASIS. Riverhead CAP maintains a current comprehensive directory of additional services to meet the participants' needs that cannot be met within the limited scope of prevention counseling. And OASIS recommends approval of the application to become an OASIS certified provider of prevention counseling services with the following contingency. The contingency is a receipt of the filing, a copy of the filing receipt from the New York State Department of State as proof that they are we need a receipt of the copy of the filing receipt from the New York State Department of State as proof of filing of their amended certificate of incorporation containing our required corporate language. Sorry about that last part.
Okay. All right. Well, they clearly don't work for the Chamber of Commerce for Riverhead, I'll say that. Anyone have any questions for, is the applicant around?
No, she couldn't make it today.
Okay. Does anyone have any questions for anybody about anything? If not, we can bring it to a vote. The motion will be for approval of this new provider. Seeing no further questions or comments, we'll vote. All those in favor, please indicate it.
Aye.
So it's unanimous, 4-0 in favor of that application. Let's move on to the last order item of business for today, 2019013, postgraduate. Ms. Holmes will be. Yes.
Okay, I do have the applicant here with me today.
All right.
Oh, I can. Yeah. Hi, my name is Yulia Vever. I'm the Deputy VP for Clinical Operations at Postgraduate Center for Mental Health.
Hi, my name is Earlene Asbury. I'm the Director of Substance Abuse Prevention and Treatment with Postgraduate Center for Mental Health.
Okay. Postgraduate Center for Mental Health is requesting OASIS approval to become a new OASIS provider of Part 822 outpatient services to be located at 1775 Grand Concourse in the Bronx. The applicant is presently licensed by New York State Department of Mental Health, and they have 2 Article 31 clinics, 3 assertive community treatment teams, and health home care coordination. Recently, the agency was issued 3-year recertifications for all 13 of their OMH licensed programs. The target population for this proposed new service are individuals with co-occurring mental health diagnoses. The provider notes that the majority of clients served by their Article 31 clinics have co-occurring substance use disorders. I think overall you treat about 1,500 folks, of which 90% have co-occurring disorders. So it is their hope to have their own outpatient substance abuse clinic to serve their folks as well as others in the community. And they've indicated that in the past, when referring their folks to other service providers, retention rates tend to be low. Patients don't typically tend to engage with the outside referral sources, and they feel that this will increase services for their population in particular. So some of the services they propose are an intensive outpatient track. These would be for individuals who would require more focused treatment. They're also going to provide substance use screening, assessments, medical assessments, individual and group counseling sessions, family counseling. They're going to refer to self-help support groups, introduce relapse prevention skills, and provide medication-assisted treatment. They anticipate treating approximately 850 patients within their first year of operation, while maintaining at any time an active caseload or census of about 75 to 100 patients. They plan to operate Monday through Saturday with hours varying from 10 a.m. to 8 p.m. We've reviewed all of their policies and procedures and have accepted them per regulatory guidelines. We've also reviewed their staffing plan, and it appears to be in regulatory requirements. Basically, they're going to hire a medical director, medical staff, several qualified licensed health professionals, including BHSACs, and peer advocates as well. From a fiscal standpoint, according to OASIS Fiscal Audit and Review Unit, the provider is fiscally viable and would qualify for a 3-year renewal term. The figures submitted show that the applicant has sufficient funds available for the initial support of the program. They have a projected annual budget for the first year of service of around $1,661,000, sources coming from Medicaid managed care, Medicare, and some federal grants. Projected expenses for the first year are around $995,000, which includes salary and wages, fringe benefits, equipment, property, and other non-personnel services. This results in a projected profit of around $665,000. they are not requesting any OASIS funds at this time. From a physical plant perspective, we sent out our folks to take a look at the physical plant. We conducted a state environmental quality review as well as a floor plan review, and all resulted favorably. No findings, no corrective action plan was needed, all within regulatory requirements. As far as support, representatives from the agency sat down with Community Board 5 back in May 15th, and received favorable support of their program. Both the county and the OASIS regional office are also indicating support of the agency and of their plans. What's interesting is the county plan for 2019 includes a desire for New Yorkers to receive more access to medication-assisted treatment, which the provider plans to do. They also have a plan to decrease mortality rates associated with the use of tobacco, and the applicant has plans in their outpatient clinic to address that as well. The agency consists of 9 board members. One in particular has substantial experience in substance abuse treatment. Therefore, it is OASIS's recommendation to approve the request from Postgraduate Center for Mental Health to become an OASIS certified provider of Part 822 outpatient services, and we have 2 contingencies. One is verification of the hiring of sufficient staff, and 2, filing receipt of amendment of charter with New York State Education Department. That's it.
Thank you. Does anyone have any questions for the state? Does anyone have any questions for the applicant? All right, and to summarize, this is an applicant who is well known to many of us. They have been in the business in the Bronx of providing OMH services. They would like to provide OASIS services because their patients tend to need both in many cases, and it would make sense for them to do it. They appear to be qualified. The location seems nice. It has the state's recommendation. Any further comments, discussions? If not, we vote. All those in favor of allowing them to do so as indicated. Another 4-0 going to the board. Full council later. That, I believe, concludes our business for today. Is that correct, guys?
You are.
Outstanding. We stand adjourned. Thank you very much. Yeah.
In New York, obviously Baltimore, and
Hi, Kate Breslin from the Schuyler Center for Analysis Tests in New York City today.
Tino Hernandez. Glenn Martin, member and chair of the project.
Brandon Mitchell from that center. Ralph Fasano, concerned for independent.
Donna DePola, member. Susan Salomon, member.
John Castan, member.
Jennifer Davis, member.
Brian Bull,
Rochester,
Steve Hansen, Oasis.
hi Steve.
Hello.
Albany,
Jim Scordo, member.
Catherine Alonge Coons, member.
Rob Kent, Oasis.
Stephanie Campbell, Oasis.
Jennifer Farrell, Oasis.
Tracy Collins, Oasis.
Lisa Rademacher, OMH.
so with the number of members in Albany, I do not think we have a quorum, if I'm mistaken.
We need 2 in Rochester to be there in order for 15 members.
But 2 anywhere.
Correct. The 2 that said they were coming to Rochester are not quite there.
Okay, all right.
They're not quite there because we know they're on the move and they're going there, or?
They had confirmed before that they were coming. They did order their lunches, and so, yes.
We're hopeful.
We're hopeful.
And the lunches are here.
What we'll do then is shift the agenda for a bit and start off with the things that don't require a quorum.
Right.
And if those individuals come and we have a quorum, then we can move on with our project review. We do not have regulations to present today, so the only thing that really requires the quorum would be the project review. But the reports from the commissioners can occur, as well as I believe Steve Hansen is going to give us a presentation as well. So we will start off, and I think Rob Kent is here to represent Arlene today, and I believe Ann will be here in a few minutes, but since she's not here at the moment. Rob, are you ready to begin your presentation for OASAC?
No, but I will.
Thank you.
Well, I'm going to be pretty brief, but now I think I'll speak for as long as it takes for Commissioner Sullivan to come into the room. So. Is she here, Lisa, or there?
She's down there.
Down there, okay. So a few things. The legislature is today, Tracy, maybe?
We hope.
The legislature ended its session yesterday, but they came back today.
Yep. They're currently in session as we speak.
They're in session as we speak.
Yep.
One of the things that they did do for our agency is we had put forward a bill, the governor had put forward a bill on behalf of our agency. We, in the midst of trying to deal with what we're dealing with and words matter and stigma connected to getting people help, we put forward a bill to change our name. We did not change the acronym. I think that takes papal dispensation, so we didn't do that. So it would still be OASAS, but we've heard frequently from people in recovery that the word abuse in the name is problematic for them, and they wish we could change it. So our name, the law will take effect immediately. It's still subject to the governor's signature, but both houses have passed the bill. When that takes hold, the governor signs it, we will be the Office of Addiction Services and Supports, OASAS. So we're taking abuse out of our name. I know for some it might not be the most earth-shatteringly important issue. I think for the recovery movement it's perceived as a pretty significant thing. They're very happy about that. They've advocated for that. I can tell you separately from the things that the commissioner reported on in the last meeting after the budget was adopted, we are in the throes of putting together the mechanics of implementing the tax credit. So I think, as we had explained last time, the governor's budget included and the legislature accepted a tax credit for employers to hiring people who are in recovery from substance use disorder, up to a $2,000 per employee credit. Our agency, OASAS, is going to determine who the eligible employers are and who the eligible employees are. We are likely going to issue some type of procurement to identify the list of eligible employers. So stay tuned on that. We are working with Tax and Finance, who will obviously have to implement the credit, be able to account for it on tax returns, et cetera. So, stay tuned on that one. We will be moving that forward. Separately, and Emil Slane and I spoke about this at the last meeting. There were significant changes made with regard to insurance access laws and parity. We are in the throes of developing guidance with our colleagues at the Department of Health and the Department of Financial Services. So stay tuned on that piece. I I can't see too well. Is she there yet?
It looks like, yes, she's there.
Wow, so I can stop, unless there's questions for me, I can very capably turn it over to Commissioner Sullivan, unless there's questions for me.
Rob, this is Patrice. I do have a quick question for you. And it's probably a no-brainer, but I want to ask anyway. You talked about the tax credit. Is this for only new hires after it's been passed? So if there's people that are currently in programs that have gone through, serious recovery things, and they're already employed in certain programs, are you just tied up to the tax credit for them, or does it only occur for people after you pass this?
So it takes effect January 1st, 2020, and it applies to new hires. And to be clear, it's across the spectrum of employment. It's for corporations, including, it could be some who are in our world who pay corporate taxes. So, but it is across the board, and it takes effect on new hires as of January 1. And just to be clear on that, it isn't just that you're going to tell us you would like to offer these tax credits and we'll put you on the list of eligible employers. We want to see a commitment to working with the local recovery community so that there's supports in place to support those individuals as you bring them in. There are employers around the state, as we're finding as we go around the state talking about this, who do this already without the tax credit. Their comments to us are these are really good employees, very responsible, very detail-oriented. They also tend to be built-in peers. They have helped organizations who've brought them in help others within the organization who might be struggling themselves or with a family member who's, with addiction issues. So, but it is moving forward.
Question?
Yeah.
Rob, so I have about 45 recovery people. If I fire them December 31st, and I rehire them January 1st, am I covered? Never mind. And he's not saying a word.
That was a rhetorical question, right, Donna Mae?
What, did you expect anything different?
We'll represent them in their unemployment insurance proceedings. So.
Okay, thank you.
Does anybody else have any questions?
What was the name?
The TAC.
Oasis, yes, and what Oasis?
Office of Addiction Supports and Services.
Services and Supports. Office of Addiction Services and Supports.
Still Oasis.
Still Oasis. Can't give up the acronym.
Well, the good thing about that is, we for years we've included gambling addiction, and when you had the Oasis name, that kind of felt like it was exclusionary. So when you say addiction, it does really incorporate all different levels of addiction that require services. So it's a great name. Thank you.
I have to look for it.
Yes, you do. Did anyone else come in? Any other members?
Mr. Hans is all by himself over there.
I know nobody else came in Rochester. Well, Steve, you'll just let us know if you get any company.
As you speak, somebody walked in the door.
Oh, Mike Martin.
Steve, I was going to tell you if they didn't come in, you could eat all the food.
We have some flooding here in upstate here, and the exit here was closed off. Some of the road in the 90s kind of, I guess, being taken away by the rain. So some people might be coming, but they'll probably be coming late.
Do you want to introduce yourself?
Oh, yes, sorry. Michael Martin, Executive Director of Native American Community Services in the series.
Thank you. We just need one more. So thank you for making it in. We have our illustrious commissioner from the Office of Mental Health. We haven't changed that name, right?
Not yet.
Okay, and she's going to present now, Dr. Sullivan.
Okay, thank you so much. And I don't know, Bob, did you mention the reappointment issue?
Not yet.
No. Okay, well, here's the good news. Basically, this has been a tough year in the legislature. Very busy, very, very, very busy. So in the midst of all the busyness, Basically, the reappointments for this committee and a number of other reappointments never got through to the Senate for approval. So we are going to be asking all of you if you would be willing to continue for another year on the Behavioral Health Services Advisory Council.
Only if Dr. Martin stays.
It's really important. First of all, I can't thank you enough for everything you've been doing. You've been a great council. And it's been really, when I think back over the years that I've been involved with the council, really you have been a very forceful council. You've come up with suggestions, you've come up with ideas, and you've really very thoughtfully looked at things that have been proposed and stepped, and some rejected some, which is good. So I think it's been a very effective council, and in many ways we'd like to have continued all of you for a longer period of time anyway, except the statute ran out after the 6 years. But there is a statute in the state which basically covers these late reappointment phenomena, which says that people can be asked to continue for a period of time. So I know I'm imposing on all of you a bit, but it's really very critical that we keep this council going, because the work of the council really informs our regulations, the PARs, the service delivery, the review of things. So everyone will receive a letter requesting you to continue, but it would be great if you could all kind of continue. Now, the way this works is that we'll be again submitting these things on right away in January, but my guess is that they're usually the last issue on the agenda. But it will not falter again because now they've delayed us for a year. So it will probably be through the session next year, so probably through June. Sometimes we get lucky, and the Senate will do things early in the session, but usually not. Usually waits until June. So I mean, it really is asking you all pretty much for another year of commitment. So I would appreciate it if everybody could. I know Maureen feels the same way. I mean, we really need you guys, and I'm just sorry that but these things happen when you try to push a number of appointments through sometimes. And if you notice, they extended the legislature one day to try to work out some of them, so they were very, very busy with a lot of things. And at some point, they just closed down and said, we're not going to do any more reappointments. And so a number of things fell off the table. So please consider it. Please hopefully say yes, and we'll be getting the word out. There's a couple of things.
I thought you were firing us.
No, I'm begging, politely, I'm begging. Please stay with us for another year, because it's really critical to work with. Council's very, very important. You guys have been great, and we were very sad that we were going to have to ask you to leave, but now you have to. A year extension due to the
That's public comment.
So thank you, everybody. Let me just say a couple of things I just wanted to bring up. One is that I think people know, I hope people know, that the Suicide Prevention Task Force report is out. Things that were in the task force report. The first one is to increasingly on community-based. The idea of this is suicide safer communities. So we're going to be doing community coalitions across the state. Now, many counties have coalitions. Some of them are very active, some of them are not. Some of them need support. If they're great, we're not going to be interfering with what people are doing. But some across the state do need some support. And we're going to also be talking with about ways that we might be able to support. It's more of a kind of coordinated approach to suicide prevention. So you need community activity. The community activity usually involves things like education, reaching out to schools, doing first responder trainings, doing all the basic public sector, community psychiatry prevention. But we're also going to be getting data. We're going to be using our systems to get the data on suicide, and the systems have gotten better to know pockets where basically there are more needs for intervention than others. We're going to be doing that across the state. So we'll have that data available to communities. And when you do that on a local level, you really find out where some of the key issues are. So we're going to be looking at certain demographic groups, et cetera, across the state and using that data. Another thing we're going to be doing within the council is looking at something called, it's got a name which I just forgot, an acronym, which is suicide-specific information to a region, which means you go through every suicide, get people together to look at all the suicides that affect your particular region. and you look at common factors. We really haven't done this in much in New York State, but we would like the coalitions to do this. It's interesting, Washington State did this a lot. They found two key things in certain areas. In one area, they found that a lot of individuals had dropped off their pets at pet stores, pet shelters before actually making the decision to commit suicide. So they basically trained pet shelter people to ask a few more questions when someone comes in. The other thing they found there in another community was a lot of suicide attempts and tragically successful suicides and evictions from homes. And basically they tried a sort of order to all the evictions, to work with people, to ask how they're doing, but not only just help them with, are you feeling depressed, but where are you going? What are you doing after this eviction? And helping, giving them the hope that there's a future. So those kinds of things you only find when you really dig down past just the numbers, but to what's actually happening in the community. So that's going to be the thrust of the community work. The second big area is the work with providers, and that's the Zero Suicide Initiative. And we're going to be continuing to work on that in a big way. We're going to be their initiative now to work with all the medical EPs on discharge planning, on both for violence issues and for self-violence as well as community violence. And we've pulled together a collaborative, and remarkably, I think almost all the medical EDs across the state that have senior care member have joined it to work with us. We sent out certain guidance, but now they're working with us as how do you really implement it? How do you really do the right kind of discharge planning from a medical ED when someone and similarly, we'll be working with the CPEPs and the other psych EDs across the state. So, and also all the work in collaborative care on suicide screening will continue, and on the suicide, zero suicide, I think in New York City it's Bronx Care, and then there's two other communities upstate that have a massive zero suicide approach, and we will continue to maybe come up with some additional collaboratives to work on that, to help providers do the very best evidence-based care. And then, as I said, we're going to be working with the data, and then we're going to be looking at particular subgroups that are at high risk. And if you looked at this year in the legislature, which is good, it's going to be, I think, a task for the Office of Mental Health. I think there have been about 6 or 7 suicide prevention bills that have been passed. Well, they're almost passed, even the last day, to set up a variety of task forces and work groups on particular subgroups that have a high incidence of suicide attempts and or suicide, actually completed suicides. And that includes vets, Latino adolescents, young black youth. I mean, this was a statistic which has come out more recently. A very young black youth in the age range of 8 to 13 across the country, a significant increase. And people are still trying to figure out why and what that all means. But we want to try to get ahead of it. In New York, we're also looking at the elderly, which has always been a high group. Rural issues. There has been a request to really put together the high rate of suicide attempts and successful suicides in rural areas has always been high, and I think Asian population. So we're going to be looking at these subgroups within the context of what I said about the community groups, and we'll be pulling together work groups in various areas. Again, looking at the numbers, where these numbers concentrate. So between the data, the community approach, the zero suicide approach, and then working on specific subgroups, the Suicide Task Force will be pushing this out over the next year and a half. Some of you may be invited to join us on some of the work groups, et cetera, to kind of implement this, across the state. Suicide prevention is multifactorial. We can do all this stuff within even our healthcare systems, but economics are a huge impact. I mean, whenever you look at statistics, when the economy goes down, successful suicides go up. So it's a huge community-based issue, but it's interesting. I'll just say one more thing about it. Chemung County is one of our counties in the upstate New York, and 10 years ago they had four completed successful suicides among adolescents. And that county got themselves together, did a really remarkable work within the county. The kind of thing we're talking about setting up is really safer suicide community within the schools, within churches, et cetera, and really had a tremendous across the board in all ages for suicide attempts and successful suicide. So when suicide coalitions and groups come together, there can be a really successful outcome. And I think you probably know about the Henry Ford group that did a really successful zero suicide approach throughout their healthcare system and dropped suicides from about, I think it was almost 70% decrease in successful suicides throughout their healthcare system. So we know that these kids can work, but they take a lot of effort, and they take the multiple factors in the community. So we'll be rolling this out over the course of the year and asking if everyone needs help. Now, as a backup to that, you obviously need services, right? And you need the first line of services that you need are the crisis services. You want to have a kind of robust crisis system that can be there, and I know everybody is probably aware we sent out to all the counties for response in the crisis system. We're getting good responses. People are working really hard across the state and in the city to get a real 2-hour response time maximum for crisis intervention services. And we're beginning to see that happen, and we're helping communities where they don't have enough resources to kind of bolster through some of the state aid how to grow that suicide response, not to the crisis response system. And then along with that is our crisis residential approach. Now this has stalled a bit. It's taken us some time to get out the regulations. And there'll be a capital RFP that'll be coming out soon, but the regulations are now, I've signed them, so I don't know if they're in some temporary limbo, but they should be out within a week or two. And that will describe 3 crisis residential services that we have. One, which is a kind of peer-supported crisis residential for serious mentally ill. The other, which is a more medically focused intensive crisis system, and then a crisis residences for kids. So those will be coming out along with it. In a month or two, we'll get out our RF for capital construction. We have $50 million to help support building if people need to build these crisis services. Now, in other states, these have taken off. Here, it seems to be a little more sluggish, partly linked, I know, to some of the issues that we have with housing, which I'll get to later. But still, I mean, we want to try to see if we can be more robust in getting these services out there, because they work. Every place that they've been put up, they've been helpful, they work. So they're going to be pushing this over the next few months, and especially with kids. We've had a personal experience in the state system with our crisis residential. We have, I think it's 4 now across the state. They've been great in terms of avoiding hospitalizations. And we're, at least within our state system, they've been so helpful as kids who pass through our system, not ending up coming back to hospitals. So to the crisis services, and they avoid acute care admissions, and they avoid hour admissions. They come to a crisis residence for 2 or 3 weeks and do really well.
So I'm just curious, will this be folded into the Medicaid benefit so that
yes, yes, yes. Now I think the I have to be clear. The mobile crisis stuff is now in the mainstream benefit. We're working to get these into the mainstream benefit. There's still some paperwork problems with moving it through CMS, et cetera. But yes, we will be moving. Part of the reason that the crisis residence installed is that it sits in the HARP benefit. It doesn't sit in the mainstream Medicaid benefit. So that means that there's a whole group of people for Medicaid who can't easily get reimbursed for. And while some commercial payers and some of the managed care companies have picked it up anyway, because they can as in lieu of, they have not been very aggressive at doing that. So I think it's going to be soon, but we're really moving to move them into the mainstream Medicaid benefit, because that's been an obstacle in getting them there.
And specific suggestion about New York City and kids. I mean, many of the kids that we see that present with suicidal ideation or attempts, repeated attempts in the past, and there's some parts of our system that are robust enough on the child side to do a good job, and many places that aren't. So kids will go to the nearest psychiatric emergency room, and there won't be a child psychiatrist available or access to one. So we've been thinking about this for a long time, that why can't we have designations or trauma designations, so that, because the ambulances go to the nearest hospital. So if you have a kid in a psychiatric crisis, you don't necessarily go to a place where anyone is competent to assess the kid, and more importantly, plan. So just a suggestion to think about, there could be ways to select sort of regional, you wouldn't work in New York City, in New York State, so regional sites, in the boroughs where EMS would selectively take kids.
Based on their acuity.
Yeah, like a trauma designation.
It wouldn't be all kids.
Yeah.
It would be certain.
Yeah, well, a kid who was suicidal or I mean, because
emergency services would know where.
Yeah, you go to if you were in Queens, you'd go to Elm.
There are parts of upstate.
Yeah, if you were in
Parts of
Northern
upstate, that would
Manhattan,
be
you go to Presbyterian. If you were in Lower Manhattan, you go to just not taking advantage like other health services do of regionalized service patterns. So
that's a good suggestion. We should talk. Let's talk about it and let's see what we can do.
I mean, one of the things that we're working on a telepsych model for Bellevue. You know about the SAM, but part of it with Bellevue as the hub, because don't listen to me over there. We have a lot of child psychiatrists at Bellevue. We don't still have child psychiatrists. But what isn't in the other hospitals is appropriate levels of child mental health specialists.
Right.
And I don't mean psychiatry, I mean social work.
Right. Yeah.
So the H&H model will involve beefing that up. So you have 2 shifts of that. So because the kids all come in the afternoon and evening. So there's a person who can actually do the intervention, tell it, can help and guide it. But so there are things we can do, and there is some reinvestment going into that already, but we should think about how to do that better, and then how to make sure people know where to go. Don't go to the wrong place, because they're just going to sit there and wait until they transfer you somewhere else. And they're going to discharge kids who can be discharged, or they're going to discharge kids without appropriate follow-up.
Now let's talk about this. Let's talk about this both in the city and state. But we'll get a group together.
Yeah.
There's 2 things to it. I think one, you're absolutely right, is where should the child go? Then in areas where maybe they can't get there, we need to set up, we've been thinking about this because you've got a hub, Northwell is doing a telehub. If we could connect some of our, they could pay for it, but if we could connect some of our other, even, upstate hospitals that kind of, even with a hub in the city or a hub with one upstate, where they could kind of get those child or social work consultations. It's worth it to them not to have somebody wait in their emergency room in a period of time that it will take. So we'll get the group together to start talking about how we can do this. And now that tele is so much more, people are much more amenable to it, I think that it set it up as a way for consultations, and we had it as an easy way for a lot of our upstate more hospitals, and even the ones in the city, to connect, like with a Bellevue or with and basically pay that consultation. But it's still worth it for them to pay for it rather than have the child and the family sitting in the emergency. So we'll set this up, okay, and we'll talk about how to spread that expertise across the state. It's a great idea.
There's a whole generation of psychiatrists who will never put on real pants. They're sitting there at their desk doing tele.
Where you're heading, because I think it will minimizes trauma, right? If you're not moving a kid around or discharging inappropriately, but also I think you could pretty easily make the case about it saving them.
And the case you can make is about saving lives.
Yes.
Because it's now the second cause of death in adolescents. And the first is accidents and overdoses, and a lot of those are suicide. So
and I think
we save a lot more lives than the healthcare system.
And I think a lot of
lives and money work on
and I think a lot of EDs, they want to do the right thing, but they don't have it right there. And EDs work, if it's not right there, it's very hard for them to incorporate what they're doing. So I think if we can set up systems which are easy for them, where they could easily access someone via, video to interview the family, interview the child, they'll do that. But you got to make it easy for them.
And also to get out of the medical model. I mean, I do a lot of national consulting around this. Most other states in the kids' service system use master's level clinicians. They have some psychiatric backup, but not much. So you don't have to be a psychiatrist to do this kind of assessment. So you can build an infrastructure in EDs, less expensive and more accessible. And then you've got one social worker in ED covering the whole ED, and a suicidal kid comes in.
So I think this could be very exciting. So we'll work on this and see, and I think we'll kind of take a look at our consultation, mixed consultation telephone with primary care doctors, having child psychiatrists, basically Project Teach, has been very successful. and a lot of primary care doctors use it and find it really helpful. So I think it's something that's spreadable to multiple issues, and we should just be using it more because it gets the real expertise out there, so people aren't kind of left kind of a bit lost, which is really good.
And we should just make it as flexible and easy to, so for example, I mean, I'm just thinking in terms of our RTFs where we have to have an on-site doc in order to just do them as a whole. That could be reviewed by a trial psychiatrist.
Good luck getting them get restraint without a doctor present. That's a tough issue.
Right.
My only fear, well, I can talk, it's come before. I know it's important, and I know people feel burdened by it. But I have two concerns. One is I do think it's the most aggressive thing that we do when we start restraining people. Incidents of bad restraints have been notorious for really some terrible. We all know that, but it's a slippery slope. The easier, to some extent, the easier you make restraining people. Let me just say. The other thing is that real eyes on and making sure you're not doing it, you're doing it appropriately medically, etc. So I'm a little concerned. So I've been holding off. I know that people are knocking on my door about this, but I think we have to be very, very thoughtful. And if we ever go to some tele way of doing it, it has to be more than just a quick glance at what's going on. But I know you feel that way, but what I'm getting is once you get these things out there, it's a little bit of a slippery slope and restraining.
But you might be able to use tele to avoid an emergency on a trip.
Yes.
Yeah.
Yeah.
I mean,
yeah, but I don't
Yes.
think at this point we can do that even.
Well, you can do it. If, restraints are something very, very specific, but if you tell it the way we've written it now, you just have to be sure you've got backup. You can do it. You could do it in patients. You could do it in patients. I don't think, we really discourage anybody from thinking they could have just telepsychiatrists in a patient unit. But you could have them as a backup, so you have one doc who's there, maybe you have somebody from telepsych who can sees maybe some stable. There's ways to do it, I think. We've done it to some not experimenting, but we're doing it a little bit in the forensic system. We have real trouble recruiting physicians.
And in the afternoons and after work hours.
Yes, yes. Then
we're having to pay incredible amounts of money to get people to work overnight. So
yeah, so we can look at those. We can look at those. Yeah. And then one last, I just wanted to mention something because I know that this has been just a very difficult issue is the housing issue the only thing I can say is we are working very hard to see what we can do in the next budget year. I know everybody in the community will be working very hard to see what we can do in the next budget year. In the meantime, I just do want to remind people that over the past 5 years, there has been $50 million that has gone into raising what was when I started close to 15,000 for a city. This is up from legacy housing to what's now 18,000. Now that doesn't solve it, but it has bumped it up. All the new housing is coming out at the higher rates, so we're really talking about the legacy housing. We have, the exempt money that we take back every year, and it's a complicated way for housing. We're not going to get that back this year from any house providers as long as they're not making a profit. And I think that's raise it and so when we take it back for some providers, that's significant. For others, it's just a drop in the bucket. But we're not going to be taking that money back. So that's something that was under our control. And then we do have the capital representatives here for the physical setup of our residences, etc. And that RFP is coming out, and that's $60 million. So people have been saying for a long time they need that. Capital money is a little bit easier to access. But we will continue, and I know that your advocacy will also continue to work on getting the legacy rates up. First, we're also working with New York City on some small populations of housing that maybe we can think about jointly working together on. But just so you know, it's still.
Quorum has arrived.
They already had the Rochester.
So thank you everyone for hanging in there. I know it's been really difficult, but it's not like we're not paying attention to it and trying to see what we can do to get housing rates approved. So I just wanted to kind of say that because I know it's on everybody's mind, and I know that this has been a disappointment for many providers in the budget. There wasn't more money allocated than just the 10 million that we did allocate. And so it's something that's going to have to be a continuing process. But, you know, we're getting good data. We've got data. I know that you're going to continue the advocacy for it. We're looking hopefully for some more support next year's budget. I know it's tough. We did put out an RFP for forensic. We're reissuing it because it's a $25,000 rate, so it's not low. But for whatever reason, I think some people didn't see it, or maybe some people are just still feeling a little bit overwhelmed by housing. But we're putting it out again. We hope we got at least 250 scatter sites at the $25,000. We got 110 assigned, but that leaves about 140 that we're still looking for taker to put us on. This is reentry hub. It's really so important because the biggest factor, just like with everything else, of individuals not going back to prison is having the right services, and often one of those key things is housing. And for a while we had housing that was successfully enabling us to put many of the really most vulnerable into housing, but we used it all up now because everybody's in that housing. So we put out this RFP to have an additional, you know, cadre of housing for those that are the most vulnerable leaving prisons, because some people still leave prison and go to shelters. Think about that. It's serious. We're trying to get young students, and that's, you know, that's like asking for a return to prison in a short period of time. So we're in the process of setting that out. We hope we'll get some more takers, and that will be successful. We'll be additional 250 units, and then there were 250 units of general scatter site, and that went out, and that was from dollars that somehow hadn't gotten used in the BHSAC, and we negotiated well to be able to get that for scatter sites in the first year of BHSAC. So at least there's some more housing coming up, and that's all coming up at the high rate. It's all kind of
Thank you, Commissioner. Does anyone have any questions from any of the sites? I see Tino has his hand up here in New York. I'm not sure if there's anyone in Albany and Rochester, but we'll start with Tino.
Is Rob still there?
I am here.
Yeah. Do you have any idea what the legislature is working on?
What was the question?
Legislature is working on?
Yeah.
Yeah.
I mean, they're passing a bunch of bills. I know they did the environmental bill yesterday, the farm laborers bill yesterday. I don't think they're going to do marijuana. They're passing a bunch of miscellaneous bills. I think a lot of the major things either were done or fell off the table. The surrogacy bill, I think, fell off. Marijuana fell off.
Was anything moving forward, any modifications in the marijuana? If legalization was not on the table, was there other for decriminalization?
Yeah, I think they're talking about.
I think they're still talking. Yeah, and I
think
think that's
come to an agreement.
Yeah, I think that's in part why they're even still here today, trying to stretch it out. But I don't know that they'll get anything on that done or not. I think they're still talking.
I also know, Rob, that there for waste, and I'm not sure, but I know waste, the Shatterproof is the big initiative that's been happening through the OASAS services. So that's hopefully everybody has been involved in that or has heard about it right now.
Yeah, we're one of the pilot states. Shatterproof's a national family advocacy organization. They're doing a pilot to create a quality metrics rating system. New York's one of 5 states that's in the pilot. So we've started that process with them to try to develop a system that would measure the right things, but measure and provide information to families, providers, other stakeholders on the quality of treatment.
Substance, right, Rob?
Yeah, it's just substance use disorder. Yep.
Commissioner, I wanted to interrupt everyone. I think, and I've heard this with the reappointments. If everybody could also, really check what we do have on our agendas, because we want to make sure that when we do have these meetings that we do have a quorum. So it was good to see the 3 folks were able to make it in, because we were on the cusp of not having a quorum. And particularly for those who are having project reviews, to have to put projects off, because we don't have a quorum is tough. So I'm glad that everybody made it in today, but I know that that was a question, that was something that Paul wanted us to address, as well as Jennifer, had brought that to my attention. So, hopefully when you look at your reappointment, I think there have been some people that have been on the council for a while that have not been here, and probably just to find out whether or not they want to continue to be a part, and that we get enough people so that we can continue, because I agree with Ann that this is an important responsibility that we do have, and I've enjoyed being a part of it. I do continue to be a part of it for the next year, and do whatever we need to do to continue to help with projects and regulations and things like that.
Hey, Patrice. Patrice?
Yes.
And do you need me to move over? Okay. Sorry, I'm moving across the room. I don't think you can see it. I was just going to add, it's Tracy, I was just going to add, in addition to what the commissioner had spoken about, I think we have lost a few people, and we'll take a closer look at this, but I think we've lost a few people on the two primary committees, so we may be looking for people not only to just stay on the full council, but we may need to replace some of those spots too, to make sure at the committee level we have quorums. So that's information that we can also provide in an email to everyone. I know not everyone's here today, but something else to think about if you're not currently on a member of project review or regulations, and that's something that you'd be able to do. We may be looking at adding some individuals to those committees as well.
Tracy, one question. Are there any, I know that, for instance, like Donna and Susan came on midway, and I think a couple of people that come up to the Rochester came on somewhere midway, so they're not coming out on their 6-year term.
Correct.
They're coming up. But is there a possibility that some of the people that vacated their seats, that their appointments could occur sooner than those of us who are ending our term, or it all had to be at the same time?
No, it's just it has to go through the legislature, so it's no way to do anything sooner than next year.
So they just stay vacant until we
we're working with the legislature. Well, we're working with the governor's appointments office to prioritize the vacancy positions to refill, understanding that legally someone sitting, even if their term is expired under the state law, they can hold over until a new person has been confirmed. Well, actually, has taken the oath of office after Senate confirmation. So, yeah, we're prioritizing those where there are vacancies.
Right, and I think some of the people who have retired in recent months and maybe this past year were part of the committees, but I'll confirm that. I know we've looked at the list, but I want to make sure I give you the accurate information. So for those spots where people have already retired or left, we'd be looking to add some people to those committees for this interim period that the commissioner spoke about, just to make sure that we have a quorum at all levels. So at the committee level as well as the full council, to keep all that work moving.
And the other thing is, I mean, I don't know if it would help, but we have these sites, and as long as we could have an additional site or two by video, and that would be something that would make a huge difference in terms of people being able to come. So if that's an issue, let us know, because as long as we got like 3, we could add more to the screen. So
what about
yeah. But if there's an area, just let us know. If that could be helpful, we'll work on it. We could work on it. As long as
And Rochester, we know you want to go to Buffalo. We're going to try to find a place in Buffalo.
We appreciate it. And sorry for the quorum scare. No. I will believe it if it's in Buffalo, I promise.
Okay, all right. So, anybody have any other questions? Thank you, Rob. Thank you, Commissioner. Appreciate it. Steve, we thought you were going to be alone. Now you have company. You're on. You're on. Steve is our Associate Commissioner for the Courts and Criminal Justice for OASIS.
Patrice? Go ahead, Steve. You can say it.
I was asked to yield my time for the time being to the Project Review Committee.
Oh, excellent. Thank you. We appreciate this. So you're going to go after the Project Review Committee. Okay, so we're going to turn it over to Dr. Glenn Martin, who is the committee chair for project review. We have some individuals that have come to also present their projects with them. So.
We'll start off with Oasis, whatever their official name is today.
Still Oasis.
Exactly, whatever it is, it's Oasis. All right, on your agenda you'll see 3 items. That's not real. The first item is proposal. Second item, Riverhead Community Awareness Program. This is a request for a new operator to provide services to schools out in Riverhead. They do a very nice job of explaining how Riverhead is a horrible place to live. They go on. They read their application, and it's not a and basically just reminding people that it may be the ritzy part of Long Island, but a lot of people who aren't takes a fair amount of attention to the alcohols and general misbehavior, mental health, and substance abuse issues among the youth, and they are prepared to provide treatment for it. I'm recommended by everyone who needs to recommend them, including local government organizations. The committee discussed. We did not have a quorum, but of the 4 people who were there, we unanimously recommend full council approval as.
So, from the committee for approval. Do we have a second?
Second.
Do we have any conflicts? Any abstentions? Have any in favor? Aye. Anybody who is against this at this time? All right, so this is approved. Thank you.
Okay, next up is 2019.013 Postgraduate Center for Mental Health. Postgraduate Center is in the Bronx. They're providing OMH services since the beginning of time. They want now to provide Oasis services in the same location in the Bronx. The location looks good. The community is for it. The organization is well known. They appear to be meeting all their criteria that are necessary, and the committee, by a 4-0 vote, recommends approval to the council at this time.
Even though the council has really recommended, because we did not have a quorum, because we have Dr. Martin and one of them. Do we have any conflicts? All in favor? Aye. All opposed? Any abstentions? Recommended approval by the full council.
All right, that concluded the Oasis agenda. We move on to OMH. Let's start off with applications 16 and 24. The conflict in yeah, I would accuse myself. John was present for our conversations, but did not participate earlier. 16 and 24 sort of go together. They're both Jewish board, both residential treatment facilities for children and adolescents, both in the same location north of here. One wishes to cut its bed count. That would be the Arthur Mann Center for Residential Treatment Facility, Sally and Anthony Mann, excuse me. Dropping from 64 to 40 beds. That's a capacity drop of 37.5%. And the other drop, the 20% drop, I believe, from 50 to 40, and that's in the Goldsmith adolescent facilities. They explained to us that in general their census has been going down. Some of it, optimistically, is due to the fact that their length of stay is going down. They're able to get people out. They're not coming back, and some of the services in the community that they and others provide may finally be having an impact, and it's not necessarily to keep the kids there as long as they have, or put them in the first place, and that they don't need to provide the services at the rate that they were. This is supported by OMH. There was a full discussion, and again, the committee recommends approval of both of these reductions, 16 as well as 24.
So did they come in as separate apps?
Yes.
Okay, so we'll do separate.
You have to vote separately. Yes. So the first one would be CPAR 16, a reduction in capacity, and that again is the Sally and Arthur Mann program going from 64 to 3.
So, we has brought this forth, and that's 4 people have already worked forth an approval. We have a conflict already with John Caston, and so all in favor? We discussed this a little bit, and let's have a discussion.
Sure.
I find this troubling as we continue to increase residential beds in adolescents. While I'm sure it's true that when changing the model, which is a good change, short of stay in involvement, has been driving down the census. There are other factors at play here. It's very hard to get kids into these programs because there's a very lengthy process of the ACT committee where they sit and review once a month and decide whether or not the kid can go. But I don't fully understand the basis for that in the reimbursement environment. It does in some ways falsely constrict the flow into these programs. And I just hate to lose any more kids residential beds. We just lost a big RTC provider in Westchester at the BHSAC site. As I told everybody earlier today, I operate a program to the Children's Center next door to Bellevue, and that's where all the kids are ending up. I specifically recommended that the JPFCS staff think about maybe converting some of those beds into beds for younger children, because we only have an RTF which will also operate.
I'm not as familiar with these programs, but in looking at this application, there's clearly a rates problem. So even after the downsizing, Jewish Board is going to have deficits of $500,000 in each program. So they're funding $1 million towards this. It's going to continue unless we fix it.
And the other issue which the JPSA staff raised, as we actually decrease the referral of kids to these programs, the same thing's going on in the JJ side, as less kids are incarcerated, the complexity of those kids goes up. And then one of the things the RTFs really struggle with is do they have a staffing model to support the needs of the kids that they have. So I just hate to see the knee-jerk, the assumption that no kid should ever be in a residential placement center is not appropriate. 70% of kids over 13 in foster care in the country are in residential placement. So that's it. Whatever you think about it, we have to have it, or we have kids living on the streets, which we now have in New York City.
I'm glad.
This is Stephanie, though. Is that the right place to serve them, though? Just because they might be coming out of foster care and ending up homeless doesn't mean we should put them in an RTF. I was in a residential treatment center, which was different, and a lot of them end up there, too, in residential treatment centers governed by OCFS. And, they're waiting to go down to a group home level, a lot of them. So to me, it's like, yeah, we have to look at what our capacity is and what services are available to people, and we should be trying to keep them out of these facilities. What are their outcomes in terms of, really staying in recovery when they leave a facility, and the connection to the family and providing services to the family so that goes well as a transition back to the home. Like, a lot of this is part of that new model, and so, it looks like they've had some of these beds available for a long period of time now. So I agree that we should be looking at it systemically, not just at the facilities.
So we talked about this a lot. I agree with you. I don't want any kid to be in residential treatment. We don't really have group homes anymore in New York City. They were closed under Mattingly's administration. They were a very good model. They were small programs with 4 or 5 kids, and they were kids who were going to be able to, they didn't have families to put them. So we don't have that option anymore, as far as I can tell. And the other issue is I still don't think the services that we have in the community to take care of these really challenged kids and these really complex families are by any means robust enough. And I don't think the HBCS services are going to meet that need.
So I got 3 people in New York that are going to have something to say, so I'm going to give it to the commissioner.
I just wanted to say that looking at the RTF model, it's an old model. They're not at such a bad rate because it's a hospital-based concept. But the kids that currently, I agree with what Jenny's saying, that are currently moving into these services are at a different level than some of the kids that took the start group and stuff. We've gotten together all the RTF guys. They all have a coalition. I just met with them 2 weeks ago. They are putting together, and JBS is part of this, they're putting together a way to approach the continuum, something that Stephanie said, and others, includes still some residential beds, but the step down capacity. When you look at these kids, they tend to bounce from this residential to the next, this to that, and I don't know that the model that we have is what really we should be using going into the future. Not saying that there shouldn't be some longer term residential bed, but what should they look like and what should their connections be to the community? I'm not trying to be, I mean, I think that many of the RTFs have been doing some really good work, but to some extent they're connecting back to families and community hasn't been as robust in some settings as I think it needs to be if they're going to be what they need to be going into the future. And the RTF people agree with me. You know, they agree with me what we met. So we're in the process of relooking at the model. We're also trying to get away from these big places. I mean, these are incredibly difficult to imagine. Kids, I mean, 60 kids in one with all these problems, it's like asking for difficulties. So when JPF says they're coming up, they're not just coming up because it's a great issue. They're coming up because clinically it doesn't make a lot of sense to have these very big places anymore. And to some extent having lower census with the ability perhaps to move some of your staff without doing anything to their rates. They won't be responsible for as many kids, and they may up the staffing level of what they need to really make the service work. And that's partly what JPS is trying to us lowering. But that's not a solution for each one to individually try to figure out how. We've got to kind of have a system that begins to look at exactly what you're saying and also looks at kids spending as little time as possible in something like a residential setting, but knowing that there will be a need for the residential setting. So while I know I'm punting a little bit here, there's 2 years before the RTFs go into managed care. At least by the current, right now they're out of it. They're out of it. They get it. There's 2 years they're going into managed care now. Whether or not we stick to that timeline or not, but technically that's the timeline on the table. If you're talking about a problem now with residential beds, 2 years from now, when this becomes a relatively high-cost residential bed in the world of managed care, we are very worried that this is not going to be so viable going into the future. So the whole thing has to be looked at, and that's what we're doing. So this is a piece of it, what JBFCS I think is doing at this point in time, but the bigger issue is a bigger, complicated thing. And basically, we have a lot of money invested in RTS. So if we can redo it in a way that can, as we said, provide strong, more community support for step down so the kids can go through to go back in basically to the community with what they need, but also having that as a kind of safety when we need it is what we're kind of looking at. So we're in the process of doing that. I think personally the state felt that what JBFCS was proposing at this time, within all this other stuff that's going on, made sense for that particular site, which has had some difficulties with the number of kids there and providing the kind of service that really those kids are there need, even though I feel like you, I always hate to see beds of any sort go down unless we're very careful about how we do it. But the whole redesign of what RTS and residential should look like is impossible. And it was a really very good meeting with the RTS. I think that they are seeing a different picture here. And that's been a while because, you know, the RTF thing is complicated by bricks and mortar and debt on buildings. It's a very complicated scenario. But I think we're all going to work together now to find a continuum for kids. And I think they should be reaching out to the community to encourage this, to community providers, to know what is needed. So just to say that about the whole process is a little bit in flux. And I think what JPF, for those couple of centers, which we've been very involved in, we community as kids, and I think that the local census will provide better care.
Can I say something? Can I respond to that? What is the plan for these kids now, though? I mean, I hear you saying that it's in the planning stages. Well, are these kids that now need the help, that are not going to be in these beds, are they falling through the cracks?
Yes.
What is going to happen to those kids?
No, the RTF world is a very interesting world. I won't go into all the gory details. There's a lot of legislation. I've never seen a program put into legislation anyplace else. They did this with the RTFs. This is why you have trouble with the PACs and everything else actually in the law. And to look at this crazy law the way it was written, you have to really kind of dice it apart. We may do that, but we want to change the model. Those particular kids, referrals, let me just say, referrals to this particular kind, which is in legislation, is paid as a hospital-based rate. It's not your traditional CTO. Those referrals generally for that particular thing have gone down drastically across the state. It's a little bit more of a backup in New York City, but upstate we have real vacancies in most of the RTFs. We have a lot of vacancies. Kids are not, it's not the PAC slowing it down and all this kind of stuff. The kids are moving into their RTCs or they're moving into crisis residences. There's other opportunities for the kids. So we do still have the issue somewhat in New York. But I mean, the feeling was that basically those particular kids that are lower anyway now, for how long was JDS?
Oh, yeah, we had, we're low, actually, we're lower than 40 beds right now, so we're not even going, we're working our way back up. So yeah, we haven't been close to the 64
for years. So now,
no kid is going to lose
But the Children's Center has got every single day 30 to 40 teenagers who fall into the cracks.
but those kids, now let's be fair here. We're working with, I'll say one more thing and then I'll let off, but I want to answer your question. The ACS group, they're working with the commissioner of ACS at this current point in time to launch something which is different. Those ACS kids have failed. 9 I've had those, some of those high kids have one RTF admission after the next RTF admission after the next RTF. They have not done well in the system. So we're setting up something called Canopy, which is something that we're really very excited about, which will enable us to have a really good, solid reassessment of those kids in the ACS who are sitting there who kind of failed to run the system, and to use and help them have a residential piece for a while we transition them to what's the best residential place for them to go. The RTF system as it exists is not the cure-all. That's part of the problem.
I know, I'm very
Madam Chair.
So I will stop now because
Hold on. I want to also understand that we really were just bringing this point towards a vote, and we're having a discussion, which is good.
That's my
but
point
I think
of
it kind
order.
of gives us pushing towards it. I do have the end first, so I would like her to go here, then you, then we can get towards a vote. That would be really nice.
This is Kate, President. I appreciate that we're having this conversation. So I just wanted to, that's everything that I kind of wanted to kind of reflect on has been said. But what I want to call out is that for me it would be helpful so we could come back with some information of what's happening next. I know that, you know, these decisions are made in a kind of a very complex environment, and I agree that rates are often an issue, you know, workforce is often an issue, and sometimes it's frustrating when we're making these yay or nay decisions without understanding what are driving those. And I'd like to see more of that, because that's what I bought into 6 years ago, was being part of a group that kind of was being thoughtful about planning for our systems.
Yes, Madam Chair, thank you so much. I must confess that as a provider, I've learned a lot about adolescent care over the last couple of years. And for this council meeting, I've learned a lot from many of you. But Madam Chair, this is an application in front of us. If we're going to talk about policy issues, I think we should put that on the agenda. But I think we, as you point out, we have a proposal, an application in front of us, and I think we should focus on that because OMH and the provider have consensus about this action that they're asking. I'm not sure we've heard anything that would in fact refute OMH or this provider's application. So I would call to order that we actually put this to vote.
That's fine. The only question I would ask in the midst of this is if, say, the vote came back and it was against, what happens then?
Legal counsel?
What happens? Say we took the vote and the vote came back that it was opposed. It was more opposed than it was for. What would happen then?
Basically, they would not be able to lower the census. Basically, the current census that they have is just.
No, this is Rob. You're an advisory council.
Well, yes, it goes to me, it goes to you, but yes.
So the ultimate decision goes to each commissioner. They take your advice. If they're going to vote, or if the commissioner is going to go in a different direction, they owe you an explanation at the next council meeting, but it's an advisory council.
Okay, that's what I thought. I just wanted to make sure everybody had an understanding of that. All right, so with that being said, we want to bring the committee, the 4 individuals that were there, for this to a vote. We had a discussion. We have one person that's abstaining because of conflict of interest. So with that being said, all approved, all approved.
The first one, remember, is 16. We're doing 2 votes.
First one is 16.
Aye.
Aye.
Okay.
Aye.
All opposed? How many opposed do we have? 1 in New York. Anything else? Anyone else? Okay. And 1 abstention. That's for the first one.
Yes.
The second one was also for the same reason. We have 1 abstention already. We've had a discussion. All in favor?
Aye.
All opposed? There's 1 here in New York, 1 abstention, and both of them are approved.
Okay.
Next one.
All right. Next up is an interesting situation. Closure of inpatient psychiatric unit at General Hospital. Soldiers and Sailors Memorial Hospital. So this is interesting for a variety of different reasons. This is a small facility. I think it's 30 general beds, 10 psych beds, located in, I know a spot on the planet I had no idea existed. Penn, New York. Not far from Watkins Glen. I'm sure it's a gorgeous spot of the country, north of one of the Finger Lakes. But basically, it's a small hospital serving a small community with small monies, and they decided to shut their psych services unilaterally and without discussion or approval with OMH or anyone else. Apparently, they eventually got around to DOH, and DOH suggested they talk to OMH. OMH did not appear to be amused and met with them on several occasions. Dr. Sullivan probably used a voice I have heard only a couple of times. And they still but basically, so the applicant was here explaining to us that basically it's, what do you want from me? I'm running a hospital that's losing money left and right. I don't have rates or anything to support it. I'm trying to provide the essential care for my guys in my community. I can't provide the psychiatric care that's there. It really doesn't make the implication is it really doesn't make a difference what it takes. I don't have the money to run it, so we've closing it down.
Or the staff.
Right. Yes, he has tried to get staff. We didn't ask how much he was paying, et cetera, et cetera. And in any event, they're in negotiations now with OMH to come up with an alternative to inpatient services, a whole panoply of services that would be able to put into place. As we understood it, as explained to us, that we were asked to vote in favor of their application to close the services with the contingency that they come up with a plan that OMH accepts going forward in terms of the change of those services into more outpatient-based services. So by doing this, we don't condone anything that they did. We add specifically, it doesn't in any way handcuff OMH going forward in terms of fines and any other administrative or other penalties they may wish to bring forth. And that this would allow this unfortunate incident to be resolved. So we accepted that argument, also expressed some displeasure with the applicant, but voted 3-1 to bring it forward to this committee with a recommendation to approve it. I think that summarizes it reasonably.
Thank you. Is there any discussion?
I have a question. So is OMH committing to resources while this provider continues to lose money during this contingency process? I'm just wondering. That's just one question I have, just as another provider.
They're no longer providing inpatient services.
Okay.
They still have outpatient services and it's not beforehand. They're still doing that, but they're inpatient. They discharge the 2 guys in February.
Okay, thank you.
I think this is very distressing and reflects a statewide challenge in running inpatient psychiatry services. Dr. Cass, BHSAC in public, a couple of months ago, we are getting paid 60 cents on the dollar for every inpatient outpatient. Hospitals is one of the reasons we're using so much money. So I don't know what we're going to do about this, but I think we're not adequately inpatient psychiatry services. I know that's not under your control, Commissioner, but the services are dying as a result of that. We cannot retain physicians because we don't have the money to pay them enough. And it's very problematic. The inpatient beds in the academic medical centers have largely been closed because they can. There's a fight going on now with Allen Pavilion up in Columbia Presbyterian. They want to head to a spine center. So we are just not going to have enough inpatient beds, and we don't like inpatient care. We don't have the real supports on the outpatient side to prevent inpatient care. So I think it's a very dangerous situation for the community. I see it on the H&H side. We can't keep physicians. And we don't have enough nurses.
No, it's a very serious issue. Nowhere else in Medicaid are, just to be clear, are you paid that amount? 65% versus most medical stuff is the 80 to 90%. It's a historic factor. It's a fact that the rates were set a long time ago. Redoing the rates is different than redoing the rates for anything else in medicine. We have pushed hard, and there is going to be an initiative to try to get redoing base rates in fall, where we're working with QH. We did get a 25% increase for kids, and which has made a difference in the ability, in fact, there's actually opening up beds for kids because the rates are, close to exactly what you're saying, and the rates are survivable. People will do it. And we got a 5%, approximately 0.5% increase across the board on adult this year. Not enough to make a difference of what we need. There's a number of machinations going on that we're trying to negotiate with the public government the way the rates are set to get those rates up. I think there's an awareness that we're at a critical point because I get applications all the time and the whole bar very tight to try to stop people from closing. This particular hospital was in financial trouble from top to bottom. It's not just site, it's everything. The vital access hospitals are small. I'm not even so sure that they only can see one or 2 patients in 5 to 6 years. So an inpatient service never fight inpatient service. I mean, so the whole thing, leaving them aside,
makes no sense.
The reality of the crisis across the state is very real, and I think that it's important to we continue to say that and for us to have my hope is also that somehow these rates are so disparate in terms of site and other services. So yes, it's very serious, and I think council and is right. And the request that we get are so it's something that.
And particularly if you look at a lot of, I do a lot of work in kids system nationally, and there are states that have no way. There's more private for profit. We don't want to go there.
We're actually, we have, another states look at us, we have a total of psychic. There's 10,000 beds across the street, and that's enormous, relative to most states, it's enormous. 2,000 civil beds still in states, of about 1,500 forensic beds, and the rest of the states have that system. I think it's a great system, because I think it keeps people, out of long-term hospital care, it can help people stabilize, get back in the community. We have our bumps, we have our problems. We're not as good as we could be in many ways. It's a great system, and you can't go. And I think that's something that's very important. Ultimately, if we have our whole community-based system humming, we could probably do with some less beds, but I don't think we're at that point now. And I think at this point now, we're the beds that are operational need to be operational. They're in places.
Yeah, so I was just saying that when in this discussion, a couple of things seem pretty obvious. Is that I don't think the psych part was an epiphenomenon here. It's clear the hospital just isn't a viable phenomenon as it exists, and that it's a DOH issue to a large extent. What was just particularly galling here is that they're clearly in the mind of the chief operating officer, I believe who he was at the facility, is that psych was completely different. That it was not an essential thing. It's not something he needed to worry about. That's not what he was there for. He was going to keep his community alive, and the mental health was just not his major importance, which I think it goes directly to the parity and the other issues that are there. It also found out that it may have to go to, I don't know if it goes to FIPIC, I certainly hope it does. It has to go to DOH, but it may be small enough it won't go back to the full committee, because then we would raise it there. But it's also maddening is, as you point out, none of it made any sense. The fact that they had a 10-bed unit never made any sense. I agree with you. The idea that they couldn't work out something with Rochester, CPEP, and a crisis unit or something that they could have come up with that would have provided good care, it's just that they didn't do any of it, and they just sort of threw up their hands, and I'm sure they're really frustrated and did it. What's the most frightening thing about this is you just can't on your own just do this sort of stuff. And I mean, from a DOH perspective, I would say even from a character and competency, people have shown they do not have the proper character to run a hospital, as far as I'm concerned, and I would argue their competence is raised in question. Now, I could argue the system isn't helping them at all, but this is, I think, really upsetting, but I don't see it, but from a committee's point of view, I think moving it forward is the appropriate action.
Hi, Kate. So I recognize that voting no on this isn't going to solve the problem. So I'm curious what happens when something like this passes through mental health. Does it sort of raise the flag for staff to say, okay, what's happening here that can inform us about what's happening in the system? Like what's wrong here? What's the lesson we can learn to prevent this happening in other places? And also sort of, especially as being a critical access hospital, what's the conversation that Office of Mental Health needs to have with Department of Health around preserving access in places where we know it's really hard? I'm just curious, kind of beyond the simple yes or no that I'll raise our hand, what happens over at OMH when something like this?
Yeah, well, basically, when he comes, first of all, came to us and yes, we were, and it's final, because you can't just close the place down. So we looked at the community, we looked very carefully at the community, we looked at the community, we looked at the liability of places. In that particular community, for a very long period of time, honestly, the inpatients have been going to 2 other hospitals that are not that far away. So they have been running a census of 2 to 3, 5 maximum, for a couple of years. And therefore, partly, they've gotten themselves into a bit of a spiral where they can no longer work there. They're not nurses, everybody. We run an inpatient. You can't run an inpatient factory vacancy. In fact, just admitting in and of itself is a very costly phenomenon to run. So there was access to these other hospitals. That was number 1, which is our biggest concern. And sometimes we've absolutely confused these things when it's clear. Everybody else is backed up. There's no access. This has happened in parts of the state. You can't close the beds, period. You just can't close them. That was not the case. So we first looked at the access and the beds, but then you look at community services and support them. And what was also clear there is what they could do is some more community-based services. They can enhance their clinic. They can do some intensive outpatient. They could do things that could serve that community well, but when someone needed absolute inpatient admission, it might be worth them going the extra hour to this other hospital where you have a real inpatient, staff to do the inpatient. So we're working with them on this, as I said, the contingency plan. They're difficult to work with even on that, partly because of money, and partly because of lack of experience doing this. I mean, the inpatient services in that particular area should be break even. Outpatient services should be break even. When you look at what they've got, it's getting them really up to starting it and doing it and enhancing their inpatient. So we look at what's inpatient. First of all, it's absolutely needed. It's turning things down. If it looks like community-based services are needed, we will look at that to see what's happening. Try to work out the best possible financially. Sometimes despite even low rates and other things, sometimes the way some things are managed, that we could do better and not. Then there's this other, I think, myth out there that other things don't make money. Things don't make money. OB services don't make money in hospitals. Hospital OB services don't make money. Big time surgical services make big time money. In many hospitals, even internal medicine has now go large because so many people are not getting admitted to internal medicine. Units can't go the way of rehab units. Rehab units closed a number of years ago because so many of them, there's so few now because their margin got so low. So I think that this is, they were with the same thing. Everybody just got rid of rehab units. So the reality is that hospitals still make choices about what makes money and what doesn't. And despite that, I still think we have to figure something out. But hospitals make choices on that, and it goes to another level which puts site services lower on the. We don't need sometimes that much more money, but we almost for other services that they cheap because they decide no one's essential. That's how the services are. So it's a very interesting dance that goes on when people talk about closing site bills. So I think that we've got to. We've also done things across the state, upstate rural areas. We got some of the rates because of improvement, because they pay so much more for health. But there is a basic inequality here. Some of the rates are really good. This particular example, particularly, I don't know if there's much of the W, but that they went about it absolutely wrong. Absolutely.
So the committee has agreed on one board as to vote at a discussion. Do we have any conflict of interest? All in favor of closing this site? Aye.
Aye.
Aye. All opposed? Abstentions? And so it is approved with the necessary changes that.
All right, next up, Alley Valley, where the applicant and the consultants decided to stay for the finale. Alley Valley, you may recall, we had presented very briefly, I think back in September. They had put in an application to open up outpatient clinics up in Rockland County, specializing in care for the Orthodox Jewish community. And the cultural and linguistic sensitivities there. At the time that it came, it really wasn't ready for prime time, so we had suggested they go away and spend some time planning a more comprehensive application that we would be able to put some meat on the bones, basically, and come back. So we're pleased to say they have done that, and they have come back with a plan to provide clinic services for children through adults. There is what looks to be a very competent, though not child board certified individual as their clinical director, an experienced social worker who has a great deal of experience, inpatient QA, and currently the last couple of years I think was heading up child programs in Westchester. And somebody else on their team, as well as new ownership, is somebody also has some clinical background. So it sounds like they took our concerns to heart and came back with a perfectly reasonable application. There was a testimony given by a other provider in the region, now going under the name of Achieve, probably known better to those in the room as, what is it, Beaker Chola, that's been providing services in that area for quite some time. They raised the issue that it's going to make big, I would say their discussion point was, we've been here a long time, we're really successful, we're growing, we're going to be in more schools, we're wonderful, everyone loves us, and these people are new, and they're going to make our lives somewhat more complicated because they're going to hire people, the same sort of people we want. So it'll increase competition and may be a problem for them. It's basically their own. There was no argument about the competence of the people or anything else. We specifically went over with OMH 2 questions, one to council and one to Keith. One was about the needs methodology, and the answer is under OMH needs methodology, there is still need. And the question to council was, do we have any obligation to consider the fiscal viability of the other providers in the area if we approve this or recommend the CO? And the answer is no, we don't. We're not here to protect people from competition. We can say no if we thought it was completely ludicrous in an oversaturated area and it was going to lead to just harm everywhere, including their own. But we don't believe this is at that level at all. So basically, we are recommending, I believe unanimously, but unofficially because we're in a quorum, approval at this time.
Is there any other discussion?
I would just like to thank you for coming forward to provide services. We were talking a lot about things that are being downsized at this meeting, and it's always really helpful for people to come forward and say we want to do this, we want to serve the population, and we're interested in doing the work. So I just wanted to thank you.
Oh, and I also want to mention, I had forgotten, there was a sort of a modification from the beginning. Initially, it was focused very much on Yiddish-speaking Orthodox Hasids and the like in that community. The local government did a good job, I think, of emphasizing that there are other people speaking other languages and other ethnic origins, for example, Creole-speaking Haitians and Spanish individuals who also have mental health needs, and there is an understanding from the clinic that they will be providing those needs also. So that was also part of the consultative process.
Okay, so the committee is recommending.
Yeah, unanimously recommended.
Unanimously approval. Are there any conflicts of interest? All in favor? Aye. Any opposed? Congratulations. Approved.
Now you get to decide if it was worth the 2 hours of your life sitting here, but that's your... Yeah, right. The hour of all our lives, right. Right. No, we won't.
Is that the last one?
No, we have one more. One more. Yeah. So we shift back down. Now we're in the Hamptons Center. So we are proposing MAG 2828 Center for Discovery Hamptons LLC. We're going to recommend approval. The Center for Discovery, basically, this is a change in ownership. This is a outfit that's approved, currently operating, and providing community residents for eating disorders and integrated treatment. Dr. Craig Brown, MD, is selling out to Dr.
Unrelated. You should have made that clear. I thought we were friends.
So I think it's legit. No?
He's selling a share.
He's selling to.
He's selling out.
He's selling out. Maybe he's retiring. He's walking out.
Actually, the words mean things.
Well, yeah, not the man's selling out. He's whatever. All right.
He's gone.
He's leaving. Dr. Brown is spending more time with his family. Dr. Brown is leaving us, and he, however, has sold to Dr. Peliquin. Dr. Peliquin is a gentleman who has been doing services like this for over 20 years, mainly out west, I believe. They've investigated the operations out there. California had nothing bad to say about the facilities. His license is a registered psychologist. His license is clean. There are no issues raised there.
and the program has been operating fine. So we see no reason not to recommend approval of the transfer of ownership from a gentleman who looks qualified for a program that appears to be lower.
Thank you. Are there any conflicts? Any discussion? All in favor? Any opposed? And it has been approved.
And with that, we have no further business to bring forward to the full council.
Thank you for your riveting discussion. Really, one question. We did not get a chance to approve the minutes because we didn't have a quorum before.
So moved.
Approved? Okay. Any changes? Thank you. Minutes have been approved, and so make sure we get it officially. And now we're going to pass the baton over to our Associate Commissioner of Reports and Criminal Justice for Webcast, Mr. Steve Hansen. You're on.
Thanks, Patrice. Commissioner Gonzalez Sanchez decided that we needed to focus in Oasis on the criminal justice effort, particularly as the opioid crisis has really moved to change the way the courts and jails are doing some operations. So she set up this unit to focus on that, and we're looking at intervention efforts, diversion, county jails, state corrections, etc. And we looked at the data, and nearly half of the non-crisis admissions to OASIS programs have some sort of criminal justice involvement, whether they're on parole or probation, involved in a drug court, or another court, which makes it about 105,000 people a year that are coming into our system. So this is a big chunk of our population that we're working with. The other is taking a look at data that's coming in nationally that recognizes that people who are being released from custody have a 12 times greater risk of death in the first month after release, and frequently that is from an opioid overdose or from suicide. So we're looking at efforts to try and cut down on that number. And so in taking a look at this, mental health has had for quite some time now the serial intercept model, in which you look at where individuals have contact with the system and how do we engage them. And the criminal justice system has been developing things that neatly fit into that model. And I'm going to mention a couple of them. In Staten Island, the HOPE model, which was heroin overdose prevention and education, was started by the DA. And this was targeting folks who would get what's called a desk appearance ticket. They would go to the jail, get processed, and then given a desk appearance ticket, which would ask them to show up in court in a couple of weeks. And what happens when you get one of those, if you're in need of treatment or need an intervention, you're not getting one at that point. So they set this up that at the point of being given a desk appearance ticket, they give the person the opportunity to be taken to the 24/7 open access center, which is just down the block from the police station. So they can go in there, they can meet with clinicians, they can meet with peers and get engaged in services. And if the person engages in services for about 2 months, the charges are dropped. And the initial data that DA was looking at showed that there were some very favorable results about lowered recidivism and higher engagement in treatment. So that's at sort of the lowest level. And the charge that mostly you would get from here is criminal possession 7th, which is the lowest charge that, in possession that we could get. And frequently it's up to the police officer as to whether or not to charge or not. Usually the reason you're in possession is because you're using and you haven't finished using all that's on your person. So now they have an option where they can take somebody to a care program. This is being replicated. It's replicated here in Monroe County, also using the 24/7 open access center where folks can go to. In the Bronx, they took a look at a step up on the sort of criminal intensity on the charges, and they would get people who would get arrested, incarcerated, be brought in for a payment, a bail decision or release on recognizance is made, and then normally you would get your case adjourned and say, okay, we'll see you back here in about 8 weeks to talk with the attorney and see where we're at. And again, the person wasn't being engaged in treatment. So they set up this OR model, the overdose avoidance and recovery, in which the person at the point of arraignment is offered the opportunity to participate in this program. There's a community agency from the Bronx that helps sort of do case management and referral to treatment. And if you, I think the Bronx used that if you had 8 sessions, was the way they counted it, they would drop the charges. And in speaking to the judge, Judge Grasso, he basically says, all I'm trying to do is get them to treatment's front door, and then hopefully you guys will do a good job of bringing them inside and getting the help that they need. So again, these are low-level possession charges, maybe 5, 6, or 7, but not more significant crimes. In Buffalo, they were taking a look at their drug court population, and then to get into drug court, you generally have a more serious crimes. You can get certain felonies that can get you, make you drug court eligible, etc. And it takes some time from point of arrest to when you actually enroll in drug court. And they were getting calls from family members, parents who were saying, Your Honor, we're sorry, my son can't participate in the program. He died of an overdose last night. So they were seeing a lot of these cases, and they decided that they needed to do something much more immediate. So they set up the Buffalo opioid court model. And what they do is that they screen everybody who's arrested and held. And if they screen positive, and it's a really non-scientific screening tool, do you have a opioid problem? Have you ever had an opioid problem? Have you ever overdosed? Have you ever been in MAT? And if you answer yes to any of those questions, you're brought down to this special docket. They explain what goes on, essentially that if you agree to the program, they suspend the prosecution, so nothing's going to happen to the criminal case. And then they get you an immediate, and I mean immediate, the clinician is downstairs from the opioid court. They go see that clinician, the clinician makes an assessment and a referral. If they're in need of inpatient services, there's a group called Save the Michaels, run by Avi and Julie Israel in Buffalo. They have a contract on a grant from Oasis where they will provide transportation to detox and inpatient programs. So they get you into treatment usually within 24 hours. If you need MAT, one of the vans, the mobile units that we've been funding, is parked outside the court every morning. And so if somebody needs to get engaged with MAT, they go downstairs, walk out the door, and the van is right in front of them. And Best Self, the agency that operates that, will get somebody engaged in MAT. And the big piece of this particular court is that immediate engagement in treatment. It's not like, okay, we can get you an appointment next Thursday, or see what you can do. They do it immediately. The state Office of Court Administration decided that they wanted to replicate that model, and they're doing 14 replications that are focused right now. 4 of them are through a separate grant that they have, and 10 of them are being supported by Oasis with SOR money, in which we're going to fund a clinician and a peer to be on site at the court every day it's operating. So again, to provide that immediate access to an assessment and a referral, peer support services, which could include transportation or other things to try and help engage the person and get them into the process. When the Buffalo court has been open about 2 years, and their sole goal was that they would eliminate overdoses. And in the 2 years since it's been open, they've only had 2, which is down significantly from what they were seeing before. So at that level, they're seeing a high level of success. The first 30 days, you appear in front of the judge every day. And then the next 60 days, it's less frequent, but they want to maintain contact and keep folks engaged. At the end of the 90 days, they make a determination about where the case is going, particularly based on how you're doing in treatment and what the criminal aspect is. Many of the charges get dropped at that point, the lower level possession charges. and some of the more serious charges will end up with a direct referral into drug court. And they've essentially completed phase one of it, the engagement and stabilization. So they're ready to engage fully in the drug court population. The Buffalo model is also serving as a national template. National groups have come in and are looking at developing operating guidelines for any other court around the country that wants to open up this model. In state corrections, they have 52 out of 53 facilities provide substance use services. The only one that doesn't is actually just sort of a reception center, downstate correctional facility, ironically located in Fishkill, which most people in the New York office would consider way upstate. They're there for a few days, and go someplace else, so there's not enough time to engage in substance use treatment. OASIS has been for quite some time working closely with docs, both in development of the curriculum for the program and doing site reviews to assess how they're doing. They hire a large number of BHSACs, people who have gotten their credential while working for a community agency and are enticed into working for state corrections, where your no-show rate is really low. They operate some very positive programs, and their main program, the ASAP program, is a 6-month-long daily half-day program that they get, and docs currently times this to occur basically right before your earliest potential release date. So if somebody's going before parole, they will have completed this program and be able to show the certificate for parole. One of the things that's new for them relatively is working on MAT. We have a couple of projects going on. With the STR grant, we have 4 sites, Edgecombe in New York City, the Willard Correctional Facility, Orleans in Western New York, and Hale Creek. We're offering Vivitrol, where we contracted with a provider who would go into the facility, provide education. Alkermes, the medication manufacturer, would provide a free first dose for the person to get prior to being released. And then the plan was that they would get referred to an outpatient program or residential program upon release where they could continue on with their medication. They are all now working on offering methadone, and we have 3 sites right now that are doing it. Bedford Hills, the female facility, has been offering for many years methadone for pregnant women who have been on methadone and have an opioid use disorder. Queensboro Correctional Facility, which has now taken folks out of Rikers Island who are parole violators with less than 120 days left in their sentence. They're maintained on methadone in Rikers. Their case for methadone is transferred from Rikers to Samaritan Village, who then provides take-home doses to the Queensboro facility during the duration of their stay. Last month, they opened up the Elmira program, and this again is taking folks from primarily right now from Rikers, but it will be from any county correctional facility that's maintaining somebody on methadone who has a sentence of less than 2 years. They are now getting their case transferred to an OTP in Binghamton. That program provides the take-home dose. They have to drive a bit further to go get it. It's about 3.5 hours both ways for that process. There's legislation that's being considered right now which would look at requiring the state correctional facility and all county facilities to be able to offer MAT. We're taking a look at what the final language will be because there are some difficulties, for example, in getting methadone in county jails or state facilities where there's not a methadone program around. But clearly buprenorphine would be an option for that. So we're working closely with docs as we look to implement that. There are at least 3 more state correction facilities that will be implementing methadone this current year. And based on where the legislation ends up, we'll see where we go from there. County jails, we've worked closely with the Conference of Local Mental Hygiene Directors and the State Sheriff's Association. We've been partnering with them to do some surveys to find out what kind of services are being offered. The legislature put in $3.75 million last year, which we were able to disperse to various counties to ensure that they either had in-house or were able to contract with somebody to bring inside the facility some counseling services for assessment, treatment, and then referral upon release. We have an additional $1 million that's been set aside that we would like to focus on increasing MAT, and we're working again closely with the conference and with the Sheriff's Association to figure out the best way to put that money out into the communities. 40 of the county jails right now currently offer naltrexone, one acting the Vivitrol, which they're getting the full shot. On this last survey that we did, 14 counties are providing methadone and or buprenorphine, and another 20 jails are interested, so we're doing things like developing training, both live and video for corrections staff on why MAT is important, how it works. We've been working with the Department of Health's AIDS Institute because they're involved in this effort too, particularly around buprenorphine. They have a grant to implement it in some county jails. Columbia University also won a HEAL grant, which was one of NIDA's huge research projects. There are 4 of them around the country. Ohio State, University of Kentucky, Boston Medical, and Columbia were the 4 sites where it was awarded. It's big bucks. Columbia's getting $89 million over 4 years to run this research project. And it involves working with 16 counties and putting into play things like hub and spoke models, enhancing communication, and a part of that is to get access to good services, including MAT in the county jail, because that population is at such high risk. We also funded through the SOAR grant some re-entry programs, particularly down in New York City through the Fortune Society and Exponents, 2 agencies that deal a lot with inmates returning from state custody, and to develop re-entry peers. So these would be folks who could focus not only on the shared substance use experience, but also with some correctional experience that would be able to help facilitate that transition and hope to address that number about the 12 times risk of mortality in that first month. So that's a brief overview of what we're doing.
That's great job. Great work. And thank you. They got a great leader with you at the helm, always has. So thank you, Steve.
Thanks, Patrice.
With that being said, does anybody have questions for Steve or comments? Dr. Brown?
I also want to echo the fact that it sounds like you folks have actually covered a large territory of things to do. I'm really appreciative of the work by Oasis in that respect. I must confess that I've always had some questions about how that is actually executed. I remember we were approached about providing some support in a jail, and the issue about having methadone and being able to do that, given the fact that it's DEA regulated in terms of storing it. I always wondered how that was overcome with the fact that if you don't have a provider in the system who is in fact authorized to provide or administer the medication, it may be challenged to be able to do so in such a setting. I mean, I don't expect you to answer now, Madam Chair, because I know that we're near the end of the day, but I think it would be useful to come back to hear how they've overcome some of those types of challenges. It would be lastly useful for you to share with us the cadre of the specialists that you have engaged in this, in fact, worthy endeavor. I think they should be applauded, and we should publicize who they are so that the rest of us can appreciate that where to go to if we have such questions.
Well, I think I can just briefly address particularly the methadone issue. Nursing homes have long been doing take-home doses for patients who can't go to the OTP, so we're mimicking that model. All of the jails and prisons have the DOH 3A pharmacy license, which allows you to provide medication to patients for whom it's prescribed. They all have a controlled substances box, which is lockable. And that is all that they need. Many of them are under the impression that it would have to open up an OTP with all of that stuff. And we said, no, you don't have to do that. You can do it this way. The National Center on Correctional Health came out with guidelines last October, which are online, which really encourage jails and prisons to implement the MAT. And then we're working on developing a toolkit which will include like sample agreements and forms and sort of explain the logistics about how to do things, particularly with methadone because it's pretty complicated. The issue of if there's no methadone program nearby that's neither available for the facility or for the person when they get released, it would not make sense to put them on methadone. It would make sense to put them on buprenorphine, which hopefully they'll have a lot better access to. And so depending on the language as the bill that comes out, we're hopefully going to have language that supports that. It currently has a piece about jails not having to provide methadone if the OASIS commissioner deems that it's not available in their area. So if that language stays final, I think that would be easier for us.
Thank you.
This is Mike Mark Rochester. I just had a couple, I don't know if they're questions or comments or suggestions. I would say, I know in Buffalo there's a pretty robust reentry task force that's working on all of the transitional issues, and I would encourage getting connected to the efforts that are happening inside as well as beginning with them so they can reinforce and support each other. And then I would also encourage engaging, I know in your state they have chaplains. I can't speak to the whole program. I know for Native Americans in the correction system, we have resources that are listed as chaplains, even though we don't consider it religion. And they do get into issues of historical trauma and reconnection back to other cultural and values that could be supportive of their recovery efforts as well. So maybe they might need to understand the issues a little bit more too. So training them, but also engaging them and reinforcing the support you're providing.
Okay. So we're trying to make connections to those local groups, so forth. We've been operating for 3 months in this capacity, so we've still got some more work to do. But great start.
Great job. Are there any other questions?
You don't have any.
Patrice, just a comment. Thanks to Steve and the OASIS staff for kind of opening some of the doors to our local jails where we've been able to have some very effective communication regarding MATs and some really remarkable work that's been done in the last 12 months as a result of the jails being much more open and understanding of the benefits of MATs and let's just say changing their old style of thinking of how inmates should be treated within a correctional facility and coming a long way to treating them in a more humane manner and looking at addiction perhaps as like any other physical illness that can be treated with the use of medications. So we've had great strides with Jefferson County and are optimistic we'll be able to have those same improved conversations with Lewis County.
That's great. Excellent. Yeah, I don't know if anybody knew that for Putnam County, our judge court, treatment court, the judge for our treatment court passed away on the bench on last Friday. And he was one of the nicest, wonderful, caring judges that we've experienced and endured, and he absolutely loved the people he served. And so, I just want to share that. It was Judge James Reeds, and it's very, it's very sad for us to lose somebody like that. And he died on the bench, so we had a heart attack. So we just, but the county became our support. So Susan and I know him very well, and he was a very good man. So, the criminal justice system, you have to right judge and the right person helping to make the right decision was compassionate. A lot of great work to be done. And so clearly Buffalo has a way that they led the way, they led the charge. And so we're grateful for what they're doing. So Steve, thank you, and please keep us abreast of all the changes that come.
Okay, thank you.
Are there any public comments from anybody in Rochester or Albany? We don't have it here, so I wanted to make sure I'd like to put that out there. So with that being said, I don't want to rush anyone. If you want to stay and hang out, you're welcome to do that. But with that being said, I have a motion to adjourn this meeting. Is anybody opposed who wants to stay? That's fine. If the meeting is adjourned, have a great day.